Very good evening, doctors. It's a matter of real honor and pride to welcome you all to this first of its kind scientific event, Best of Napcon 2021. Mankind Pharma is India's number one pharmaceutical company in terms of prescription, and we are among the top three companies in India. In its core, Mankind Pharma is highly passionate and we are agile to the changing need. Our vision is to become the most innovative pharmaceutical company which is backed by science to serve its purpose of serving life. To expand its horizon and to strengthen the presence in respiratory market, we have launched a dedicated respiratory division called Asplis Mankind. And we are really thankful to each one of you for the acceptance which you all have given to the Asplis Mankind team. As Asplis, we aim to serve the life of respiratory patient through best-in-class quality and innovative products which are affordable and accessible to all Indians. It is with this thought we have launched India's first DMF-grade respiratory brand in our portfolio. Through this journey, we are deeply committed to have a meaningful contribution to the changing needs of lung healthcare. This Best of Napcon is also part of that commitment, and through this program, we envision to take the learning crux of the most successful Napcon Varanasi to larger number of clinicians. We have made a very tailored scientific content which we believe will definitely enrich your clinical practice. We are really thankful to the leadership of Indian Chest Society and also the core organizing committee to contribute and to help us in planning and executing this Best of Napcon. We are especially thankful to Dr. Rajesh Swarnakar, Dr. Rajadhar, and Dr. J.K. Samaria for their valuable contribution in this program. We are also thankful to Dr. Rajesh V and Dr. Nitin Napankar to serve as the scientific chair of this Best of Napcon. We are sure that this program you all are going to like very much, and it will be a fruitful event for all of you. So now let me call upon Dr. Rajesh Swarnakar, National Secretary of Indian Chest Society, to officially commence the first ever Best of Napcon and also to introduce today's moderate to all of you. Wishing you all a great view. Thank you very much.
Hello, my dear friends, and welcome to this inaugural event. So the Napcon 2021 was indeed a different one from many perspectives. It took place after a gap of 2.5 years, but it was a mega success indeed in terms of holistic academic coverage. However, it may have happened that many of you have missed it due to various reasons. But now, Napcon's best faculty are coming to your doorstep once again as Indian Chest Society for the first time ever brings Best of Napcon. Indian Chest Society has been consistently involved, as you're aware, my friends, in bringing the best in respiratory in all possible forms, be it making Indian-specific guidelines, virtual and physical CMEs. We are bringing Hummus Respiratory in India now. We have the best journal, Lung India, and your favorite best journal, best newsletter, Respire. So, Best of Napcon is our next endeavor in the same direction to strengthen our academic presence. In Best of Napcon, we will be bringing all live clinical scenarios on the major subspecialties of respiratory with your favorite subject experts and panelists giving their opinion and drawing the conclusions for you. We at the Indian Chest Society are confident that Best of Napcon will give you all the latest insights from stalwarts in the respiratory field. We thank aspires mankind to be part of this best of Napcon and bringing it to your doorsteps. At this moment, I welcome the program director of Best of Napcon, Dr. Raja Dhar, who's director of training and education initiatives of Indian Chess Society, and my very good friend who is going to be your moderator of today's session to take this ahead. So over to you, Dr. Raja.
Hello, friends. Thank you so much, Dr. Rajesh Swarnakar, for the introduction. We bring you Best of Napcon today, and I'm very pleased that we have managed to encapsulate bits of Napcon which we think would be relevant to all of you. A thank you to Mankind Pharma for having supported this endeavor. You understand we had Napcon for more than 3 days. And to encapsulate that into a few hours is nothing short of challenging. Hence, the best format for the Napcon toppers was to try and do this in the form of case discussions. Hence, we have tried to cover every bit of pulmonology, of respiratory medicine for half an hour each. We will have a moderator who will select cases which are relevant to your clinical practice. And we have eminent panelists, the very best in the country, who would dissect the cases, tell you the management, the treatment course for these individuals based on best evidence and their clinical experience accumulated over lots of years. So we hope these sessions will be interactive. There'll be opportunities for you to discuss the cases with the faculty, and hopefully this will be an experience for all of you to remember. So let me, without wasting any more time, get on with the first bit, which is to talk about the best of pulmonary tuberculosis. The moderator for this session is none other than Dr. Amita Nene. Amita is known well to all of you. And she's a very dear friend, one of the best academicians that we have in the country today. She is popular for these sessions that she does herself on a regular basis. And the reason we have started with her is because we couldn't think of anyone better to get the ball rolling for Napcon 2022, What's the Very Best. She has done multiple book chapters, scientific publications. She's an instructor for basic life support and advanced cardiac life support courses conducted by the American Heart Association, examiner for MD and DNB pulmonology exams. She's also been good enough to support a lot of faculties to become DNB examiners. Her colleagues, people who are befitting, have been supported by her, and I have also been one of those. She's the recipient of the prestigious Times Healthcare Award of Young Achiever in the field of pulmonology. And she's got many more accolades even outside the slide that is there in front of you. And she was a bright student, a wonderful student, gold medals, first exam in MD, examination of DETRD. She's also got multifarious other talents. She's a brilliant singer. She has got a great knack for whatever is artistic. We look forward to the first session from Dr. Amita Nene.
Good evening, everybody. It's indeed a pleasure to be here and to be talking to y'all about nothing else but the best of Napcon 2022. It was wonderful meeting all of y'all at Varanasi, and we had excellent scientific deliberations, and to make sure that we didn't miss anything that was happening in all the wonderful program halls. I have some very, very special, some very, very celebrated faculty across India, my very dear friends, my dear colleagues, who are going to enlighten us on very important aspects of certain things about TB. So I'd like to introduce my very, very well-known faculty. To begin with, a very beautiful lady, Dr. Radha Munje. She heads the respiratory medicine department at IGGMC Nagpur. She is a wonderful friend of mine who I even call up in the middle of the night and wake her up. and she's doing excellent work in TB, very committed, very enthusiastic, and full of life. After Dr. Radha Munje, I have a very, very, very dear friend of mine, Dr. Sanjeev Nair, who I know for so many years together, who's doing fantastic work in TB. If I get a little confused about anything in TB, I just pick up my phone and ask him, and he's always happy to answer. So Dr. Sanjeev Nair is Associate Professor at the Department of Pulmonary Medicine at the Government Medical College, Trishur. And he's going to give us some very important information today. And most importantly, I have my young friend, full of life, doing fantastic work, none other than Dr. Ravi Doshi, who is just there everywhere, putting in his own bit to help out humanity. So Dr. Ravi Doshi is consultant and interventional pulmonologist at CD Multispeciality Hospital, Indore. He's doing a lot of work in TB. And of course, we know how much work he's done in COVID. He also got an award for his excellent work in COVID. So with this fantastic faculty, let's start today's panel discussion on TB. So let me start first with a case and let's see what we feel about this. So I want to start my case with a 23-year-old lady without any comorbidities. She had headache, fever, vomiting, weight loss, anorexia of 1 month duration. MRI brain was done, which showed mild patchy basal meningitis, no cerebral edema, no raised intracranial tension, no tuberculomas. When LP-CSF was taken out, lumbar puncture was done, which showed it was an exudate, lymphocytic predominant, ADA raised. CB-NAT was done, but MTB was not detected, and the CSF was sent for TB culture. So as per the weight of the patient, she was put on correct doses-based EHRZ. The fever responded in 7 days. Appetite got better in 10 days. She gained 2 kgs of weight in 2 weeks. So everybody was very happy. However, in the 3rd week, the patient developed convulsions, drowsiness, and her sensorium went down. An MRI brain was done, which showed dense basal meningitis with raised intracranial tension with hydrocephalus. So the patient had definitely worsened. She had progressed. So Dr. Ravi, please tell me, where did we go wrong? What could have been the cause of this sudden worsening?
Well, apparently, ma'am, as per the case history, all the investigations do point toward a proper diagnosis of CNS tuberculosis. Anti-tubercular treatment was started. But what I strongly feel is that a paradoxical reaction might have developed, and the reason could be that we had not mentioned about using steroids in this particular case scenario. So I think that might be one of the reasons why this patient initially showed improvement, but later on deteriorated.
Excellent. So can you tell us what are paradoxical reactions, just so that we all are on the same page?
Well, paradoxical reactions, initially there has to be a period of improvement, whereby on starting the medication, the patient will show good clinical recovery. But then over a period of time, suddenly there is the worsening of those symptoms. The patient might go into newer life-threatening situations which initially were not there, which could be related to an inflammatory storm, basically. And there could also be unmasking of hidden infections in some cases.
Okay, so basically this is very, very important point given that even if CNS TB is mild to begin with, steroids are very, very important to prevent paradoxical reactions, because in CNS TB, it's a closed space. So when the body starts responding to dying antigens, at that time, there's no place to accommodate the edema, which is going to cause pressure on the brain. Now I'd like to ask Dr. Sanjeev, so what is the role of steroids in CNS TB?
Thank you, Amita, for that question. So basically, CNS TB as such is one of the forms of TB with the highest mortality that we have. So even with treatment, often we have extremely high mortality in our patients with CNS TB. And one modality which can actually reduce the mortality in CNS TB to a great extent by around 25% is use of steroids. So all guidelines all over the world recommend steroids in CNS TB, which actually reduce the mortality, which is the most important thing we want to do. We want to save lives, and we can significantly save lives by adding steroids early. Now, obviously, the next effect that we want by giving steroids in any form of TB, including CNS TB, is to reduce the sequelae or the long-term effects that happen along with this. Particularly, this is more true in CNS TB, where at times at the end of cure, patient ends up with a lot of sequelae and difficulties like hydrocephalus and all, which affects the long-term prognosis. However, in this regard, the evidence is not very certain. So the Cochrane review says that in terms of reducing the sequelae due to CNS TB, use of steroids may not really help. The evidence is not very clear. However, in terms of expert opinion, if you talk to neurologists or if you look by our own national guidelines on extra-pulmonary TB, the expert opinion is that there might be some reduction in the disabling neurological symptoms also. So whatever the reasons, everything put together, the use of steroids is recommended for CNS TB. So definitely, when we talk in terms of use of steroids in TB, this is number one on the list, and I'm sure that is why you put up this case first. Thank you for that.
No, very well said. I really liked what you said. So basically, we all know that it reduces mortality. However, there's not enough convincing evidence about reduced neurological deficits. But all the neurological friends, as Dr. Sanjeev rightly said, insist that we use steroids, and I completely agree, because steroids will reduce inflammation, they'll reduce cerebral edema, and most importantly, they'll prevent vasculitis, of small vessels, which is very important. So thank you for this great information, Dr. Sanjeev. Now I'd like to come to Dr. Radha. So we all know we have to use steroids, but not many people tell us what are the doses of steroids, and anybody just uses anything. So can you please tell us what is the dose of steroids that we should be using?
Yes. Basically, when a patient of CNS tuberculosis or meningitis comes up, you have to assess clinically and look at in which stage the patient is. So like the patient which you presented was clearly in stage 1 and did not have much exaggerated symptoms of CNS tuberculosis. And that is where we missed using steroids. So that is a stage which you should not miss and start steroids, and the recommended dose is injection dexamethasone of 0.3 milligrams per kilogram IV in the first week, and then it is 0.2 milligram in the second week and 0.1 in the third week. After the third week, you can switch to oral, and then it would be tablet dexamethasone, and again the dose is 3 milligrams. There it was 0.3, now it is 3 milligram per kilogram, 3 milligrams per day orally. And then it would be 2 and then 1 for the 6th week. And then you can, you have to evaluate the patient. And since the patient is in stage 1, they may not need a prolongation of steroids, and you can safely stop. When the stage is advanced, where the GCS score is 14 and there may be some focal neurological deficit. And with this, we should also be very vigilant in looking at the involvement of various cranial nerves or any other symptom which point to the focal neurological involvement. It may not be in a form of deficit, it can be involvement also. And here you need to have the total duration of steroids are 8 weeks, and the dose is now increased. So it is starts with 0.4 milligrams per kilogram IV in the first week. Then it would be 0.3 milligrams per kilogram in the second week, then 0.2 and 0.1 in the fourth week. And after that, you switch to oral, that it would be tablet dexamethasone, and the dose will be 4 milligrams per day orally and onwards. And here again, I would say that now, because the stage has been advanced, you have to assess the patient clinically also and weigh what is the response. Because, whenever patient is put on steroids, these are the drugs which is going to give you the initial response. And these are the drugs which are going to definitely, even if there is a lacking evidence, we know that complications of hydrocephalus and symptoms related with raised intracranial tension are known to occur if steroids are not used. And definitely steroids have this effect where all these complications can be prevented.
Yeah, wonderful, Dr. Radha, because the thing is that, these are the actual steroid doses which you have said. And in fact, when you were saying, I also just put up a slide over here because it's difficult for sometimes for people to kind of retain it the first time. So I request all the audience, please take a picture of this photo of stage 1 dose and this photo of stage 2, stage 3 TB meningitis steroid dose. because this is what we are forgetting. Often our neurologist friends also don't know the correct dose. We are underdosing the steroids, and therefore we are, our patients are ending up with hydrocephalus and different types of cranial nerve deficits. Okay, so I'd like to come to Dr. Ravi, that the fear always is that what if it was not paradoxical reaction, and what if it was MDR TB, because the CB-NAT didn't work out. We live in Bombay, so if the CB-NAT, instead of CB-NAT, we do Gene Expert Ultra. So if at all we did Gene Expert Ultra, that also did not detect MTB. Do we have any other molecular test which can tell us that this is sensitive or resistant TB?
Yes, we do have a test which is very commonly used in your part of the country, which is pyrosequencing molecular diagnostic test. Pyrosequencing XDR tuberculosis test, to be more particular, can give us a broad overview of what is exactly happening in that CSF fluid. It gives results quite similar to our Gene Expert Ultra. It detects almost all the common drug first line and second line mutations. It usually the process and the turnover time is roughly of around 12 to 18 hours, but it's reported within 2 to 3 days commonly by most labs. But I think if we have pyrosequencing XDR-TB, then in this clinical situation, we can diagnose what is going on and whether it is a paradoxical reaction or XDR or drug-resistant TB.
Yeah, so this was a very important point for those places in India where pyrosequencing is available. Please note that pyrosequencing is the most sensitive molecular test, even better than CB-NAT or Gene Expert Ultra, for diagnosis of CNS TB, for detection of MTB, and also for knowing resistance to rifampicin. And just like LPA, it also tells about INH, ethylamide, aminoglycosides, and the quinolones. All right. So now we come to Dr. Sanjeev Nair. So Dr. Sanjeev, tell us that if at all this was actually MDR TB, if we did CB-NAT and it showed rifampicin resistant, then how would you have treated this patient of MDR spine TB?
Thank you, Dr. Amita. I think we come from two different parts of India. You come from the richer part of India, and we come from a part where we depend a lot on our government services, and we do have good government services. And I come from the program, as you know. So from the program point of view, just to add to what Dr. Ravi was just saying, so from the program, we strive to give all the diagnostics and treatment free of cost to our patients. So pyrosequencing is obviously not part of the program right now. So what happens in my part of the country is that, for every case of extra-pulmonary TB, particularly for CNS TB, we always make an attempt at the very beginning. So you had asked what went wrong with this case. So, coming back to that question, from the very beginning, any case of extra-pulmonary TB, we try to make a microbiologically confirmed diagnosis, which will also, along with the microbiological confirmation, we will also get a diagnosis of drug resistance from the very beginning. So, that is something we strive for. It is a difficult task in India because, our high percentage of extra-pulmonary TB in India do not get that access to universal DST, which is part of the program policy. But in Kerala, at least, we have been trying very hard, and our percentage of extra-pulmonary TB getting into a universal DST is definitely on the increase. So in the very onset, what we would do where a pyrosequencing is not available is this is a precious sample that we get. We often even do surgeries to get a sample in CNS TB. So it's not an easy thing to repeat. So in that case, from the very beginning, we take the sample, which goes for a liquid culture and for all the other molecular tests which are available in the program. And like you rightly said, a diagnosis of drug-resistant TB, MDR TB, can be made only on a microbiological confirmation, and it's a lab diagnosis. So once we have a diagnosis of rifampicin resistance, generally in the program, we have actually two regimes. There's a shorter regime as well as a longer regime. But CNS TB being a more severe form of TB, the program guidelines very clearly say that this patient should be going on to the longer regime, which is a bedaquiline-containing regime, which is currently given. It's a 5-drug regime with bedaquiline, linezolid, levofloxacin, cycloserine, and clofazimine, which for bedaquiline going for the first 6 months, and then going other drugs continuing for a total of about 18 to 20 months. So in case of CNS TB, often even with steroids may be given for a long period when they don't respond, and the duration may not be so rigid as with the other forms of TB. So we might even have a longer duration some of our patients, but generally they respond well with the duration of about 18 to 20 months.
Yeah. So this is a very important point. CNS TB, the shorter bedaquiline regime is not to be used because it's a severe form of TB. So if it's MDR, then longer regime only is to be used. So, we all know Kerala is doing so well in TB. And if there's any state in our country, then it's Kerala who may achieve TB eradication sometime in life. we all are really lagging behind. Bombay is performing worse because we are the MDR TB capital. So Dr. Sanjeev, you told us about, other extrapulmonary TB, you being really active. So are you all seeing MDR TB and other extrapulmonary TB? What are you all seeing?
Yeah, we do see extrapulmonary. I mean, logically speaking, drug resistance should be as common in extrapulmonary TB as in pulmonary TB. So there should not be any difference between pulmonary and extrapulmonary. And Dr. Radha is also, part of the program in a big way from Maharashtra. So in the program, initially, in fact, the testing for extrapulmonary TB was not taken up to that extent. But in Kerala, the first case of MDR we diagnosed was actually one of the extrapulmonary we diagnosed in 2008 itself. So since then, we have been screening our extrapulmonary TB, all our cases with for universal DST. As you know, the commonest form of extrapulmonary TB is lymph node TB, which is the most common form. And lymph node TB, definitely you have access to a node. The only issue is that often our surgical colleagues, they are not aware that you have the facility for looking at isolating the bacteria as well as taking a culture to diagnose drug resistance. So the node might just go to histopathology without the node going into a bacteriological testing. So that is something that we have been trying hard, discussing with our ortho colleagues, with our neurologists. Neurologists obviously are aware, but orthopedicians, surgeons, or gastroenterologists and all, we keep discussing with them to make them send one additional sample along with the sample that goes to histopathology to also go for testing for isolating the bacteria, making microbiological confirmation, and also to get a diagnosis of drug resistance. So we do get a significant proportion of our drug resistant TB are in extrapulmonary TB. Of course, the yield also is different from various forms of TB. So lymph node TB, the yield of these molecular tests is quite high as compared to some of the other forms like say pleural TB, for example. So in lymph node TB, obviously you have the maximum diagnosed extrapulmonary TB would come in lymph node TB, not because it is more common in lymph node TB, but because that is where we get the yield. Whereas for other forms of extrapulmonary TB, you may not even get a sample in a TB spine if you're not done a surgery, which we try to get our neurosurgeons or orthopedicians to do. But often they feel that their MRI diagnosis is good enough and they are ready to go with the anti-TB drugs. They have been
Wonderful. The point very well taken. We just want everybody to know that MDR TB is not restricted only to the lungs, and every extrapulmonary TB site can have MDR TB. And going ahead with what Dr. Sanjeev Nair said about spine TB, so I'm very happy and proud to say that the largest series of MDR TB in the spine in the world, I'm one of the authors, and we have 475 cases of biopsy-proven MDR spine TB patients. And we don't really do surgeries. Luckily, we have radiologists and spine specialists who are aggressive. So we do CT-guided biopsies, and we get huge chunks of granulation tissue. They do bone biopsies also. And of course, if there is pus, then life is easy. But the important part is that MDR TB does exist in extrapulmonary TB also. And therefore, please make sure you get a sample for this. So, okay, so this was great. We did the first case about CNS TB, which tells us that however limited, however small is the TB involvement of the brain, starting steroids right from the beginning as per the stage of the disease and as per the presence of neurological deficit is mandatory, because otherwise you will push the patient into getting hydrocephalus, and it may even cost him life or a lot of loss of cranial nerve. So this is very, very important. And we also now know the dose. Dr. Radha told us about the dose. Dr. Ravi told us about the paradoxical reactions. And Dr. Sanjeev told us very important that if it's MDR TB, then shorter bedaquiline regime cannot be used. We have to use the all-long oral regime for CNS TB. I'd like to now talk about my second case. So 48-year-old male, a diabetic, presented with fever, weight loss, heaviness in the chest, and dyspnea on exertion. This is what the chest X-ray showed. You can see it is water bottle heart. There was pericardial effusion. 2D echo confirmed massive pericardial effusion. Pericardial tap was done, which showed exudate, lymphocytic fluid, ADA raised. CB-NAT showed MTB detected, rifampicin resistance not detected. The patient was put on EHRZ. Initial improvement over 2 weeks in fever, anorexia. However, 6 weeks later, patient developed increased breathlessness, edema feet, and puffiness of face. Repeat echo showed constrictive pericarditis. So, Dr. Ravi, I'd like to ask you now. So, basically, what happened? What did we go wrong, and what we should have done?
Well, I feel, ma'am, this could be the same situation where steroids should have been used, I feel. And steroids in a proper way would have helped in preventing some of the complications which may happen in tubercular pericarditis. Like it might prevent the accumulation of a lot of inflammatory cytokines in the pericardial area, or because of the pericardial fluid quantity being increasing, sometimes the cardiac function is a bit limited. So I feel it was the introduction of steroids which might have been needed in this particular case.
Yeah, so basically, this is again very important. CNS TB and pericardial TB require introduction of steroids right from the beginning because the space available is very, very limited.
Yes.
So when there is paradoxical reaction and extra fluid starts getting exuded, there is just no place. And therefore, in CNS TB, there's pressure on the brain, whereas in pericardial TB, there's pressure on the heart, and therefore it can lead to constriction, cardiac tamponade, etc. So starting steroids in pericardial TB right from day one is important. So what is the dose? Can you please tell Dr. Ravi about, to us about the dose? Because again, we know we have to write steroids, but we don't know what is the dose that is important. And anybody writes any dose of steroids. So can you please tell us the dose?
Ma'am, if we are using oral steroids, then prednisolone initially we give in 60 milligram per kg dose for the first 4 weeks, followed by 30 milligram per kg for the next 4 weeks. Then 15 milligram per kg for next 2 weeks, followed by 5 milligram per kg for the last 1 week. So total for a duration of around 11 weeks, this total steroid regimen is given.
So this is very, very important that 60 milligrams per day, not 60 milligrams per kg, but it's 60 milligrams
per
per
day.
day of
Per day.
isotope is given for 4 full weeks. And this is very, very important that because normally people write 20 milligrams and 30 milligrams, it doesn't really help. So it's an 11-week course, starting with 60 milligrams for the first 4 weeks, then 30 milligrams a day for the next 4 weeks, 15 milligrams a day for 9th and 10th week, and 5 milligrams a day for the 11th week. This is what is recommended. There are enough studies which have shown that this is the dose that works and this is the dose that is to be given. So please note everybody that if it's CNS and pericardial TB, then we definitely want to use steroids. You know, I have actually mainly decided to talk about the role of steroids in TB because, you know, we kind of get scared about using steroids in TB. But the fact is that for certain TB, steroids are actually life-saving. And unfortunately, there's not much details given. We all know what is the regime for shorter bedaquiline, MDR TB. We know the longer. We basically know the BPAL regime. All these things are available everywhere. But if we have to get data about the dose of steroids, when to use, where to use, we are kind of confused. So we want to really dedicate this entire panel to use of steroids in TB because in certain situations, it can actually be life-saving. So after this, I'd like to come to Dr. Sanjeev. So what is the role of steroids in pulmonary TB? Do we ever use it?
So pulmonary TB, I mean, at the end of the day, pulmonary TB is also like we talked about CNS TB, you end up with a lot of sequelae, fibrosis, even small airway disease, all those things happen. So logically over the years, you know, people have been trying to use steroids in pulmonary TB, hoping that that will improve outcomes. But unfortunately, or fortunately, the Cochrane review says that when we use steroids in normal forms of pulmonary TB, whatever outcomes they studied in terms of reducing mortality or in terms of reducing sequelae, did not really, you know, have that much of an advantage. So generally, the norm is that in pulmonary TB, there we do not use steroids along with. In fact, there are studies on NSAIDs as well in pulmonary TB. Those also are not very conclusive. But you may have certain forms of pulmonary TB in which steroids may have a role if the patient comes to you with sudden hypoxia, which can be seen in TB. ARDS can occur in TB. So if a patient actually comes with ARDS, steroids might have a role. And we should always remember that many forms of extrapulmonary TB come with pulmonary TB, which is often missed, or pulmonary TB may come with other forms of extrapulmonary TB. So we need to have an active search for other forms of extrapulmonary TB in our pulmonary TB patient, maybe having a meningitis which is missed or a adrenal crisis which we are not looking at. So those things we should be alert for, and in those conditions you may need steroids. So those are a case-to-case basis, clinical decision. But generally, if somebody asks me, I would say that in the normal pulmonary TB patient, there may not be any.
Excellent. So there are very few patients of TB who can actually present acutely with TB pneumonia going to TB ARDS, that is the only time we use the steroids in pulmonary TB. Otherwise, as Dr. Sanjeev said, we don't otherwise use it. And the steroid of choice is methylprednisolone. Usually the dose is 40 milligrams BD, and then we slowly taper it based on the condition of the patient. So now I'd like to come to Dr. Radha. So what is the role of steroids in miliary TB? Because, when I was a student at that time, miliary TB, we were supposed to give steroids to everybody. And of course, we know this is not true. So what is the role of steroids currently in miliary TB?
Basically, Amita, that's a good question. Steroids are basically not indicated in patients of miliary TB. And we all know that there is a risk of having more complications because miliary TB itself is a disseminated form of tuberculosis. However, when this patients of miliary TB has, as we are saying, it's disseminated, so it's likely that few of the patients of miliary TB come with CNS TB, or say within few days may manifest some CNS symptoms. So this is the time when steroids are indicated and it should be given. That is one. And secondly, even patients of miliary TB can present with ARDS. And that is the time when steroids have to be prescribed, and it would be life-saving for the patient.
Right. So, as you rightly said, ARDS because of TB, very often miliary TB can present with CNS TB, and therefore it is mandatory in miliary TB, even if the patient doesn't complain of headache, you should ideally do an MRI brain with contrast, and you will actually find tuberculomas, and you have to start steroids immediately, even if patients don't have any symptoms of CNS TB. Steroids, you'll be starting DEXA, the dose that Dr. Radha already told us about. And the third indication is adrenal TB. So when we have disseminated miliary TB, often the miliary adrenal glands get involved. But because over here it's gradual involvement, the patients are managing with reduced steroid levels. And once we start rifampicin for the patient, we all know steroids get affected. Rifampicin is going to stimulate cytochrome P450. And therefore the steroid dose also of the body, which adrenal is producing, becomes half. And when we start AKT, these people will actually go into adrenal crisis. They'll present with hypotension, and the BP will not respond to fluids, it will not respond to NORAD, not even to vasopressin. Very often they get ventilated because of this. And actually the treatment is to diagnose adrenal TB, adrenal crisis, and give them actually steroids. Hydrocortisone over here would be life-saving. So as Dr. Radha rightly said, a patient of biliary TB routinely does not require steroids, and they are not to be given. Unless patient has CNS TB, look for it. Unless patient has adrenal TB, please actively look for it. Or if the patient has hypoxia because of TB ARDS. So thank you, Dr. Radha, for this answer. Now I'd like to ask Dr. Ravi. So Dr. Ravi is majorly into interventional pulmonology. So let's ask him a question related to that. So do steroids have any role in endobronchial TB?
Well, ma'am, the role remains controversial, but still, if there is a diagnosis, then a prompt and early treatment before actually fibrosis happens is very necessary to prevent few potentially long-term catastrophic and delimiting complications in endobronchial TB. Particularly if there are several types of endobronchial TB in which fibrosis and stenosis may happen more, like edematous or hyperemic variety in endobronchial TB, which is actively caseating, or where there are tumorous growths present, tumorous type of endobronchial tuberculosis on bronchoscopic imaging. So in these particular cases, we should start steroids at the earliest, and we should give them for at least 4 to 6 weeks in a dose of nearly 1 milligram per kg, followed by by slow tapering.
Yeah, so very important. The thing is that the patient has endobronchial TB. And if you have diagnosed it in time, if you have, a patient, you have to start AKT, and within 2 to 4 weeks, if you're going to start steroids before actually completely stenosis takes place, then steroids would definitely help. That is number one. The second thing is, in fact, the Cochrane review also says that studies were really different, but the studies where steroids were started earlier, studies where steroids were given, we have 7 images of endobronchial TB. So if the endobronchial TB is actively caseating, you see a lot of caseation, or if you see hyperemia, you see a lot of edema, or you see tumorous, bulky kind of lesions. Over here, if you start steroids, then it actually prevents stenosis. And the third thing is that the dose is very, very important. So the dose is 1 milligrams per kg per day to be given for 4 to 6 full weeks. This full dose is given for 4 to 6 weeks, and then you taper over 4 to 6 weeks. So this is very important. If you give smaller dose and then say it's not helping, then this was not the best thing to do. So endobronchial TB also has steroids helping if started in time. Now, something very important to Dr. Sanjeev, steroids are sounding just so fascinating. So what is the role of steroids in pleural TB? Can you please tell us?
Pleural TB is the form of TB where we have seen a sea change in the way we manage cases. So when I was a student, all my patients with pleural effusion used to get steroid. So it was a norm that you give steroids in all cases of pleural TB. But over the years, the evidence started creeping in, and that there was a lot of debate on risk versus benefit. And there is a Cochrane review, which is a bit old when compared to the other Cochrane reviews that we were discussing. But it basically says that there is some benefit, there is a bit of benefit in terms of reducing the fibrosis and thickening that occurs in pleural TB. But overall, you have side effects on the other side. And so the evidence is not so very clear to say whether it should be given or not. At the end of the day, in terms of guidelines, the national guidelines and all do not recommend giving steroids in pleural TB. So I think those days when we used to give steroids left and right in all our pleural TB are gone. And today, probably selected cases of pleural TB where you may be able to think of a indication. Those might be the cases who might get steroids. So routinely giving steroids in pleural TB is no longer part of the guidelines.
Yeah, excellent. So basically the thing is that studies have shown that if you're going to do therapeutic pleural tapping, if you're going to give correct AKT, which is working in correct doses, then long-term effect at the end of treatment, whether the patient receives steroids or not, is the same. Because even if you give steroids to the patient, then the amount of pleural thickening or the FVC of the patient doesn't really change. So I totally agree with Dr. Nair and also our guidelines that we are not to give steroids in pleural TB. If at all I end up giving steroids in pleural TB is only when, because of the hypersensitive reaction, the pleural fluid keeps on filling up and filling up and filling up, and you're aspirating and aspirating and aspirating. And eventually the patient says, now I'm tired, I don't want a tube and I don't want repeated aspirations. Then I may just give steroids for about 4 weeks just to make my life easy, telling patients very well that this is only going to prevent further aspirations. But and this is only to help the hypersensitivity, because we know that in pleural TB, the fluid is often accumulating because of the hypersensitivity reaction. So pleural TB, steroids are not to be used routinely. Now coming to Dr. Radha, lymph node TB, the most common extrapulmonary TB. What is the role of steroids in lymph node TB? Do we use them routinely? And when do we use them, if at all?
Yes, routinely we do not advocate and recommend use of steroids for management of lymph node TB. Luckily, most of the lymph node TB that we see are superficial ones, and we can easily monitor response to treatment. But as you have shown in earlier 2 cases, few of our cases of lymph node TB also initially respond to treatment, and then there is suddenly increase in the size of the lymph node as well as the number of lymph nodes. And this is again, I feel, is high risk in many of the cases. And here is the role of steroids, which you should be prescribing to your patients along with the anti-TB treatment, which is continued, and observe what is the response of those suddenly enlarged lymph nodes, even in seronegative cases. This is a very well-known phenomenon in HIV seropositives, but we do see such type of reactions even in seronegative cases who have lymphadenitis. So I think that is the time when you should be prescribing.
So thank you. So basically I would like to say that, lymph node TB is very, very frustrating.
Yes.
Because the patient basically keeps on getting increased size of lymph nodes, new lymph nodes come up in new places. So if I have lymph node TB, I never start AKT without knowing the rifampicin status. So
Yes.
TB lymph node is something in which aspirate the pus, do a USG guided biopsy or do excision biopsy, but please try your best to know whether it's sensitive or resistant TB, because when the lymph node increases in size, you don't know whether it's sensitive or resistant, and often people just start resistance treatment. A paradoxical reaction in lymph node TB is very, very common. So in fact, lymph nodes will keep on swelling up. So normally we keep on aspirating pus. But if patients really get tired and they refuse, then you could either excise the lymph nodes or you could actually give a small course of steroids for 4 weeks. Another indication is when people have mediastinal lymph nodes, and if all the increase in size,
Compression.
often they compress on the breathing, on the airways and all, and patients actually present with stridor, hypoxia, etc. sometimes SVC obstruction also. So this is a time when you want to give steroids in mediastinal TB. So thank you, Dr. Radha. This was interesting. Dr. Sanjeev, one quick question. So what is the interaction between steroids and AKT? Will AKT do anything to steroids?
Yeah, I mean, rifampicin, as you know, interacts with a lot of drugs, and steroid is one group of drugs with which it interacts. The bioavailability or the blood levels of steroids, particularly at the tissue level, can be reduced by around 40 to 60%, almost to the tune of 60%. So we have to keep this in mind when we actually are giving these together, and we may have to adjust the dose of steroids as per the interaction that is happening between these drugs.
Exactly. So if the patient is getting AKT and also steroids, so if the rifampicin is going on, then please double the dose of steroids. If you want to give the patient 40 mg, then you actually need to give 80 mg. But this is only if the patient is on rifampicin. So all the doses that we spoke about, pericardial TB, CNS TB, endobronchial TB, these doses are applicable if the patient is getting rifampicin. If the patient is not getting rifampicin, the doses are going to be exactly half. So I'd like to wind up this discussion where Dr. Ravi is going to contribute and help us. So Dr. Ravi, please tell us steroids in TB, when to use definitely and when to use suggestively.
Well, ma'am, absolute indications of using steroids in tuberculosis, like we have discussed in cases of CNS tuberculosis, pericardial tuberculosis, if a miliary tuberculosis patient is going into ARDS, developing hypoxemia, and if we are picking up hypotension in the form of adrenal tuberculosis, then these are absolute indications of giving steroids in TB. There are some relative indications like iris. If there are paradoxical reactions in iris, then you need to give it. Or if a patient is having life-threatening side effects to anti-tubercular like Stevens-Johnson syndrome, then you need to give steroids very quickly. Or if endobronchial tuberculosis, like we mentioned, those which tend to stenose early, you should start endobronchial tuberculosis patients on steroids early. And even in patients in pediatrics, abdominal tuberculosis has showing good results, although yet to be proven in adults. But these are a few situations where steroids and tuberculosis are definitely to be given.
Excellent. And I think even genitourinary TB, normally guidelines don't talk, but our urology friends swear by it that we have to really use it. So thank you so much, all the very learned, very brilliant, very bright panelists for giving us so much information on the role of steroids in TB. Dear audience, I just want you all to know, CNS TB, pericardial TB, you have to use steroids. Endobronchial TB, if diagnosed early, if it is hyperemic, if it is caseating, if it's tumorous types, please use steroids. If the patient has symptoms of TB for more than 3 months, there's a high chance of adrenal involvement. Please do the serum electrolytes. So if the patient has hyponatremia or hyperkalemia or hypomagnesemia or hypoglycemia, probably the patient has early adrenal involvement. Do the serum cortisol levels, do the ACTH test. And if you have any adrenal TB suspicion, then please give steroids to these patients to prevent adrenal crisis. So thank you so much, everybody. This was fantastic discussion. And I would like to thank ICS. I would like to thank Mankind for this great initiative. And thank you, audience, for logging in. Thank you, dear panelists. Thank you, everybody.
Thank you, Amita. That was wonderful learning for all of us. Thank you.
Thank you.
Thank you so much, Amita. That was a wonderful session. A lot of learning points, which are very nicely being teased out for this particular session for all of you. Let's now move on quickly to session number 2, to be moderated by my good friend, Dr. Rajesh V, who's a senior consultant and head of pulmonary medicine, Rajagiri Hospital, Kochi. Rajesh is a young, enthusiastic pulmonologist who's built up a huge reputation for himself, not just in the southern part of the country, but all over the country. He is a reputed faculty, a sought-after faculty for academic forums throughout the country. He's developed many guest lectures at international and national platforms, as also zonal and state platforms for pulmonology and for critical care. He has multiple publications. His teaching career, interestingly, has already spanned 15 years. I would have thought he's too young to have a 15-year teaching career. However, he's trained and guided MD, DNB, and DM residents in respiratory medicine. He's a very popular mentor for all his postgraduate trainees, and he's a good friend to many of us. So he's going to moderate a session on lung infections. I'm sure the topics, the disease processes that he selected in this huge topic will be of a lot of relevance, and I'll leave it to Dr. Rajeshwi to introduce his panelists to you.
Thanks a lot, Raja sir, for those kind words, and a very good evening to the esteemed faculty and delegates. At the outset, let me congratulate the ICS office bearers, specifically Dr. Rajesh Swarnakar, Dr. Rajadhar. I would also like to place upon record our sincere gratitude for allowing all of us to be a part of this very accomplished organizing team and a very knowledgeable and reputed bunch of faculty. Respiratory medicine as a specialty has grown in leaps and bounds in the last 2 or 3 decades. And although there are glamorous subspecialties like interventional pulmonology and sleep medicine that have emerged in the last couple of decades, I would still say and believe that the bulk and charm of respiratory practice in our country lies in respiratory infections and obstructive airway diseases. And this is precisely what we are trying to discuss today. Infections is what we are trying to discuss in this panel today. When it comes to the panelists, I don't think anyone will require any introduction today. But as is customary, it's my duty to introduce each one of them. And it is needless to say that all of them are luminaries par excellence right at the national level. So without much delay, let me share the panelist details with you. Are my slides visible?
Yes, sir.
Yes. Okay. First of all, I would like to welcome and invite Dr. Ashok Garbat. Sir is the senior pulmonologist from Nagpur. He is the chairman and managing director of KRIMS Hospitals, Nagpur. He is a member of the editorial board of International Journal of COPD and editorial board member of the Airway Diseases Journal. He is a fellow and member of American College of Chest Physicians. He is a president of the Vidarbha Hospitals Association and ex-president of Vidarbha Chest Association. We are privileged to have you here, sir, and very happy to welcome you.
Thank you.
And secondly, we have Professor Yuvarajan from Puducherry. He is professor and head of SMV MCH Puducherry, and very handsome and really hero-like figure, Dr. Yuvarajan. He was awarded the European Diploma in Respiratory Medicine from ERS, Switzerland, and he is a regular invited faculty in European Respiratory Society Congress year after year, and he was selected as a prestigious future leader in the international workshop on lung health held in Prague in January 2020. Also awarded as an outstanding pulmonologist of the decade in the National Conference of Pulmosleep Meet held in Nagpur.
Thank you, sir. Thank you, sir.
Thank you, Dr. Shiva. And third, we have Dr. Joydeep Ganguly, who actually hails from Berhampur in West Bengal. He is a European diploma in adult respiratory medicine and postgraduate diploma in diabetology. He practices as his own clinic in Berhampur, West Bengal, and he was an ex-RMO in Murshidabad Medical College and ex-assistant professor in Sikkim Manipal Medical Institute of Medical Sciences, Gangtok, Sikkim. So we have a very formidable panel that is lined up. Ashok sir, Dr. and Dr. Jaydeep, and I am very fortunate to have all of you together here. So the first case I will just share with you. This is a 58-year-old lady with very well-controlled diabetes mellitus. She had a COVID infection 4 months back, uneventful, no pneumonia, and now after 4 months she has presented with fever, cough, shortness of breath, and wheeze. She is tachypneic, hypoxic, tachycardic. The chest X-ray as well as the CT scan of the chest bilateral shows bilateral midzone and lower zone alveolar shadows, new alveolar shadows with right-sided and left-sided small pleural effusions. Elevated total counts, neutrophilia, worsening creatinine, raised CRP, raised D-dimer, NT-proBNP, etc., etc. So I will just start off with Ashok sir. Sir, the first question to you, sir. So here is a patient in the post-COVID phase coming with new respiratory symptoms and new lung shadows. So what would be the differentials that you would like to consider? How would you like to evaluate this patient? and how crucial are microbial tests like the PCR, rapid microbial tests like the PCR-based tests and the multi-choice?
Looking at the CT picture, looking at the clinical picture, and looking at the investigation given to us, mostly it is like bacterial infection, could be fungal infection also, and along with that is a high pro-BNP. There is an element of cardiac failure also. But unlikely to be tuberculosis, unlikely to be thromboembolism. And about the investigation, I would like to have certain investigations like sputum examination. If possible, patient is fit for the bronchoscopic ball, then ball will be also useful. And other than that, the ECG, echo, BNP, CRP, D-dimer is already done also. And I would like to go for a test which is give me a very quick, because it is a progressive. Last 2 days this has happened, and very progressive disease, maybe a bacterial infection which is thought to be a severe type of infection. So I would like to go for a test like a BioFire, which is a complete pneumonia multiplex, which is available, and we can get a result within 24 hours. The things with the BioFire is like that, it can give about the infection, but it doesn't give a massive value, one thing. Second thing, it is a costly, around, it may cost, at our place, it costs around 16,000 for the patient, which include around 34 types of, parameters, which include viruses, bacteria, atypical pneumonia, fungi, and all these things.
Thank you so much, sir. So the messages from sir are very clear cut, and this was precisely the things that were discussed in a couple of sessions of the Napcon 2021 in Varanasi also, that post-COVID phase, we have a lot of things to think when a patient comes with lung shadows, tachypnea, respiratory failure and all, including the infections, bacterial, invasive fungal, including Aspergillosis as well as mucor. Then tuberculosis is known to have relapses after the steroid therapy, thromboembolism, cardiac failure, multi-system inflammatory syndrome, etc. And we know that early invasive sampling with sputum if available, good sputum if available, BAL, CTPA, echo, ECG, all those things are very important. So the same patient, as we continue, she had accelerated hypertension, pulmonary edema, worsening, needed mechanical ventilation. And once she was ventilated, we went ahead with the bronchoscopy and BAL. The microbial test with BioFire detected Acinetobacter calcoaceticus bowmani complex. Count was more than 10⁵. And this particular isolate was NDM as well as IMP positive. So the second question to Dr. Yuvarajan would be that what are the usual multi-drug resistant organisms that you encounter in your own practice, both community acquired as well as hospital acquired pneumonias, and the resistance pattern as well as the treatment options that you can think of?
Sir, regarding this case and regarding the query also, regarding the drug resistant pathogens, like what I used to see in my day-to-day practice. Usually, I used to see that in ICU, sir, mostly in ICU. Basically, like Klebsiella pneumonia, Enterobacteriaceae families, other families like E. coli, Pseudomonas aeruginosa, Acinetobacter baumannii. As in our case, it has grown Acinetobacter baumannii and all. So these are the common, drug-resistant pathogens. Particularly, it is very common in gram-negative pneumonias in ICUs. In addition to that, there are certain patients with having high risk factors for developing this MRSAs also. So we need to consider. So when you are considering this MRSA, we need to see the local pattern, we need to see the hospital pattern, and we need to collect the catchment area. What is the prevailing resistance pattern? All these things we need to consider. As you all know that the drug resistance is one of the important clinical problem that we may face in day-to-day practice. See, particularly with Klebsiella pneumonia, Pseudomonas and all these things, see, we have very few options. Nowadays, most of the times when we see all these things, common resistance is because of beta-lactamases in community based community acquired pneumonia, whereas in ICU we see extended spectrum beta-lactamases. These are the enzymes which can inactivate your extended spectrum beta-lactam rings. So that's why the piptas, piperacillin, tazobactam and other higher antibiotics we use in ICUs may not work for these drug-resistant pathogens. nowadays, in addition to this, we also see carbapenem resistance also, which is one of the real threat, because these are the higher antibiotics we are choosing in our ICU practice. So carbapenem resistance actually due to various factors. There are common thing like in the year 2012, like New Delhi, metallo beta lactamases and LMD and VAM. And these are the different enzymes that are released which will inactivate your carbapenems, which is another important drug that we use for a gram-negative pneumonia in ICU. And the treatment options, what we were discussing, like when we are seeing the ESBL, that is extended spectrum beta lactamases, like we have very few options that we have to depend on carbapenems. We have to depend on imipenem, meropenem, and all these things. In addition to that, we can choose an antibiotic which is not having beta lactam ring, because the beta lactamase will inactivate the beta lactam ring. So we have to choose, we have to depend on that antibiotics. We can choose aminoglycosides, we can choose fluoroquinolones. But in case of critically ill patients, we should not depend on single agent. We always have to give a combination when you give aminoglycosides and also when you give fluoroquinolones as per the recent guidelines.
Correct, correct. Perfect, perfect. Thank you, Dr. Yuvarajan. And two brilliant points that came from your discussion was, one is, look at the local sensitivity pattern rather than anything else. And secondly, look at the patient profile for specific risk factors that place him at high risk for specific bugs. So by and large, in most Indian ICU settings, it is a multi-drug resistant gram-negative bacilli that really pose a problem, like E. coli and Klebsiella, non-fermenters like Pseudomonas and Acinetobacter. MRSA, yes, you get a few MRSAs, but not to the tune of the West. And if we were just continuing with this particular patient, the renal functions actually showed an improving trend, and the lung shadows also improved. She was extubated, etc., etc. So she had a good outcome. So again, I'm just reiterating the things that Dr. Yuvarajan said. What are the treatment options and strategies for multi-drug resistant gram-negative infections of the lungs? I'm just putting it as a second question because just to get a second perspective from you also, and plus this is the most important aspect of lung infection. So I think it will be a recapitulation. And again on MRSA lung infections, the incidence and outcomes.
Yes. Thank you, Dr. Venkat. As previously beautifully explained by Dr. Yuvarajan, that we have two kinds of infection here. First, either we have a gram-negative MDR infection or may have MRSA. So talking about this gram-negative MDR infections, we have different kind of mechanism there, such as efflux pump. We have difficult to drug penetration because of biofilm formation, and we also have some porine mutation, so that the drug penetration cannot occur, and also there is selective mutation of the drug targets. So depending on the bacteria, we can divide it into three factors. So it may be ESBL producing, or it may be carbapenem producing, like Enterobacteriaceae, or it may be Pseudomonas aeruginosa, or it may be Acinetobacter as per our cases. So it's our Infectious Diseases Guidelines Society of America have beautifully just released in the 7th March of 2022 specific guideline regarding what to offer in these cases. So apart from this carbapenem resistant pattern, you can have these new molecules, like we have the newer beta lactamase inhibitors like ceftazidime plus avibactam, or we can have meropenem plus verobactam, and another imipenem, cilastatin, and rilebactam. So these are the newer beta lactamase inhibitor which are more potent, and somehow they are more effective in encountering this ESBL producing organism or carbapenem producing organism. Regarding older therapies, there is some precaution is there because most of the people are critically ill in these cases. So we should take care of this renal function, because we know that if we use the an alternative like colistin or polymyxin B, there is a lot of nephrotoxicity and neurotoxicity may be there. So we should always cautious, and we can have a different kind of approach, like how we can importantly effective treatment can be given, like we can give supratherapeutic doses, like we can give high dose carbapenems, like in case of meropenem we can give it 2 gram IVTDS, and we can have this particular pharmacokinetic and pharmacodynamic interaction, because we know that some antibiotics are concentration dependent and some are time dependent. So we can actually adjust those doses to see what effective concentration and effective time dependent killing of bacteria occur. And also we can have newer biotics, those which are not very much in number, like we have plazomicin, which is a newer generation amino acid, then we have idavacycline, which is a newer generation of tetracyclines, and we have some newer generation beta lactamase inhibitor, which I've already discussed, like varobactam or rilebactam or this avibactam. But we should remain cautious about using those, because these are the last resort in our weaponry. So we should have steady and we should be cautious about all the patient's profile. Individualistic approach is very necessary, and that's all. And regarding MRSA, I would like to say that with MRSA nowadays, from I read a study from this recent 2019 publication, and they say that it become endemic in India. In western of India, it is about 20% of incidence of MRSA, and in southern India, it's about 50%. Though I practice in the eastern region, there is no specific data regarding MRSA infection. Definitely, we will do a study about that. And regarding treatment of MRSA, all the guidelines have shown that linezolid, especially as it can be given in oral route, is more effective and less side effect occurring than vancomycin. That's all. Thank you.
Sir, one more point to add, sir, to be
Yes.
added, like for this NDM group of this, especially for carbon-resistant strains, there is one new cephalosporin which is very much active. I don't know whether it is available in India, but it is very much trust in IDSA society. That is Cefidrecol, which is a siderophore cephalosporin, which acts very well against this NMD IMP strains. Like,
and it is also this newer ITSA guideline. They say that in case of asymptomatic pulmonary infection, which are carbapenems producing, or CRAB, they call it CRAB. So this CRAB infection, this cefidrecol is an absolute choice. Yes.
Excellent choice. Yeah.
Thank you so much, Dr. Joydeep and Dr. Yuvraj. And I think you have almost summarized 4 or 5 lectures of Varanasi 2021 in 10 minutes. I think that's a very creditable thing, and I think the message has really gone across to the delegates in a very concise manner. Thank you so much for that. We move to a separate case. The first 3 questions were with one particular lady. This is another, again, a real-life case. This is a patient with COPD, 63-year-old gentleman with COPD, very severe COPD based on his lung functions. Frequent exacerbator, almost 3 exacerbations in the last year, 4 exacerbations this year with 1 hospitalization, frequent steroid use, etc. So he comes to with an exacerbation. This is the X-ray and this is his CT scan at presentation. So he has bilateral cavitating lesions in the CT scan. So Ashok sir, a few questions to you that what are the possibilities for bilateral cavitating lesions in this particular patient, and how to suspect and diagnose invasive pulmonary Aspergillosis infections, specifically in COPD patients with biomarkers also?
Yeah, thanks. This is 63-year-old female, severe COPD because the FEV1 is 36%. She had frequent exacerbation 3 in last 1 year, hospitalization also, and she had a short systemic steroid burst also. So looking at the possibilities and the already she had a steroid burst. She was hospitalized, she had exacerbations, and she has on the CT chest, she had a cavitating shadows bilaterally. So more likely we can suspect, can it be a staphylococcus infection? Can it be gram-negative bacillus? Could it be Aspergillosis, septic emboli, or cavitating infarcts? So these are the few things which we can keep in the differential diagnosis. But looking at her spectrum, looking at her history, it's mostly appears like she had a infection like a invasive Aspergillosis sort of infection. Then go for the biomarkers. What are the biomarkers which are available presently for the investigation of Aspergillosis? There are several molecules could be used as a biomarker of infection, but 2 of them are of special interest. One is the Aspergillus galactomannan, that is GM, and second is the B-glucon. Now, the tissue biopsy is also very important in case of it is Aspergillosis or hunger culture is important. But blood test as a quick diagnostic for invasive Aspergillosis in the disease also important, because this patient is severely immune sort of systems. The positive reports, positive results of the galactomannan may favor the diagnosis of Aspergillosis, but then again if we go for the valve, then it will become a very difficult whether it is an invasive aspergillosis or it is it is not invasive also. So all depends of the galactomannan level also. The detection of the valve does not differentiate the colonization versus the invasive disease. So looking at the things, I think both the test, particularly galactomannan, but the galactomannan may be false positive in many patients, those who are having some antibiotics like piperacillin, tazobactam, amoxicillin also. If patient is having IVG also, then patient may be having some sort of other infections. Patient having certain blood products also can give a false positive.
Again, thanks, Ashok sir. I think you have very nicely put across the possibilities of bilateral cavitating lesions in a COPD patient. I think that would be something which any postgraduate student would love to hear. Continuing with the same patient. So we have a patient who has a high probability of having an invasive pulmonary aspergillus infection. So what would be the medical management of an invasive pulmonary aspergillus infection? What would be the drugs, the choice of drugs, the duration of therapy, response monitoring, and all those things? And especially after this COVID era, we do get a lot of zygomycetes infection of the mucor infections of the lungs. So your thoughts and your experience on the medical management of mucor also.
The options that what we have is it's very well known that when we see an invasive pulmonary aspergillosis, there is no other thing like we can give azole only. Voriconazole is a gold standard drug of choice for these patients who presents with clinical features, and once you confirm that the patient is IPA, we can go ahead with voriconazole. So voriconazole dosing usually 6 mg per kg per day we used to give first day, and then we can reduce it to 4 mg per kg next day, and then later you can change it to oral drugs also. And it has a very good bioavailability and it works excellently if you start early for this group of patients. And regarding the other drugs, like what we can use is that for most of the systemic and invasive fungal infections, we can try amphotericin. The only problem with amphotericin B deoxycholate is that it has high nephrotoxicity and it excretes the kidney, and all risk of infusion risk reactions are there with the conventional amphotericin B deoxycholate. So that's why there are other options of amphotericin B, that is liposomal amphotericin B, and then amphotericin lipid complex, and then colloidal form. These are the things that commonly we use in our clinical practice for this group of patients. Among all these four, this amphotericin, I used to prefer liposomal amphotericin because dosing will be adequate and it achieves a very good concentration. The risk of nephrotoxicity is very, very less, and then infusion reactions also less. And then it is also, only problem is that liposomal amphotericin is the cost of the therapy. And other options, very good option is that we can try isavuconazole also. So you all know that isavuconazole is one of the very good azole. We can choose this drug even if you are not very sure that what fungus you are seeing, because most of the times we have a doubt whether what we are seeing invasive pulmonary or invasive mucor. Sometimes we may not get a good a clue from the microbiology friends. So in this group of patients, isavuconazole is one of the azole that we can try for both the fungus, like both the IPA and both for zygomycetes. Isavuconazole is the best drug that can be given. So these are the options, and you can have we can use posaconazole also. All the three azoles are very active. Posaconazole is available now. Previously, it was only in suspension. The problem with the suspension of posaconazole is that it has a very bad bioavailability. We may not be very sure that how far it reaches the target site. But now we have an injection posaconazole, we have a tablet posaconazole, which is contracting all these things. We can use that also. And when you choose all these drugs, definitely voriconazole plays a better role. If you're not choosing voriconazole because of other issues, if you think that resistance is there. And one more thing, like we can do a susceptibility testing, like as we do for other bacterial organisms. But only thing is that there are very few centers which do susceptibility testing for fungus. And coming on to the mucormycosis, as you know that pulmonary aspergillosis is very easy to treat with the medical, whatever armamentarium what we have with the drugs. But mucormycosis, when the word is itself, which shows that is usually it is a localized aggressive disease, and it can cause extensive necrosis. So whatever antifungal what you give, it won't reach sufficient concentration to target site. So basically, the best therapy will be a surgical resection wherever it is there. including if it is in lung. If it is in the lung, we have to do a lobectomy or pneumonectomy, whatever it is possible, along with antifungal. So the antifungal that is commonly being used for mucor is amphotericin B. So usually liposomal amphotericin B 5 mg per kg per day can be given. It has to mix with the dextrose and has to be given slow infusion, has to be 100 ml slow infusion has to be given. And this liposomal amphotericin B has to be given for long duration. And there is high risk of hypokalemia infusion reaction is also there. You have to repeatedly monitor the potassium levels while giving this drug. And second most important drug I told you is that isavuconazole. Isavuconazole is only azole that is active against both Aspergillus and also mucor. You don't have to see the what invasive fungus we are doing. Isavuconazole works better with both the organisms. Sir, one point to be added: if you are not very sure, using voriconazole will aggravate the proliferation or will induce the proliferation of mucor. So voriconazole should not be given in mucor suspected, sir.
Exactly. I think the point very well taken. So if the microbiologist is not able to really differentiate between the two, probably go ahead with the fossa or even a isavuconazole so that both are covered. And till the time the microbiology lab comes back and tells us that no, this is not mycor and this is Aspergillus. So point very well taken, Dr. Yuvraj. Thank you. Last case, this is a 30-year-old gentleman with frequent respiratory infections right from childhood and frequent infective exacerbations. Previous positive culture of Pseudomonas thrice in the last 1 year. So this is the X-ray and CT. Of course, he has cardiogenic syndrome, situs inversus with bilateral extensive cystic bronchiectasis. So the questions that I would like to put across to Dr. Joydeep is, what would be the choice of antimicrobial agent in an acute infective exacerbation of bronchiectasis? That's the first question. And the role of Pseudomonas colonization in non-cystic fibrosis bronchiectasis, how does it affect the natural history? And what are the techniques available, medical techniques available for eradication therapy of Pseudomonas and other potentially pathogenic microorganisms in non-cystic fibrosis bronchiectasis?
So in that case, the acute exacerbation should be treated by previous sputum report. So every bronchiectasis patient, as he or she recurrently admitted to the hospital, there is a chances of bacterial resistance. So we can know from the previous antibiogram and the sputum culture report what is the sensitive antibiotics or resistant antibiotic, and as in that case 3 times Pseudomonas aeruginosa have been seen, so we can safely assume that is a presence of Pseudomonas aeruginosa is present, and there can be some kind of resistance is there. So we can see we have to see the previous sputum culture report. If we can send the culture report for the present infection, and we can choose an antibiotic that is anti-pseudomonal, sensitive to the previous sputum profile or present sputum profile, and give it to at least for 14 days. Because if we see there is a specific ERS guideline for bronchiectasis management, and according to them, 14 days treatment is very important to control infective exacerbation of bronchiectasis. And regarding the choice of antibiotic, also it's somehow different in Indian population to that of the European and US population. In Indian and population, the study that have been done, it was seen multicenter study that about most of the people are suffering from Pseudomonas enterobacteriaceae like Klebsiella and E. coli, and also some infection with Ebomani. But in US and Europe, there is a lot of cases of Moraxella catarrhalis, Streptopneumonia, and Haemophilus influenzae. So regarding that also, we have to keep in mind that we have some specific population-based infection, and according to the sputum culture report, and the individualistic approach should be taken, and sensitive antibiotics, preferably anti-pseudomonal antibiotic, very sensitive to piperacillin, we can give it to them for at least 14 days. Now, regarding in bronchiectasis patient, colonization and in chronic bronchial infection are two separate things. So how to differentiate it by clinically? So if a patient have some colonization of with some specific bacteria like Pseudomonas or others, and if it just produces no inflammatory response, only some expectoration sputum, we can safely call it a colonization. But when there is an inflammatory reactions and given so many inflammatory symptom, clinical symptom like fever and other symptom, we can call it chronic bronchial infection. The thing is, both including colonization and chronic bronchial infection has to take seriously, and we need to eradicate the first sputum report as soon as possible, because what is happening, as much as the patient is having recurrent exacerbation, especially with Pseudomonas aeruginosa, the lung function will decrease. There is a poor quality of life. There is recurrent hospitalization, and economic burden is there, and also patient quality of life is decreased. So the eradication is utmost important. Now, regarding eradication, if we see the guidelines, we have 3 options. We can start by the ciprofloxacin 750 milligram BD for 14 days, follow it up with either inhaled or injectable, and it should be continued after 3 months. Another thing is we could start with the injectable antibiotic, anti-pseudomonas preferably, give it for 2 weeks and then follow it up with inhalational or oral antibiotic. Or in the third option, we can use at first both oral and inhalational antibiotics and follow it by either injectable or inhalational antibiotic.
Okay, Dr. Joydeep. So the messages that we need to pass to the delegates is that in an acute exacerbation of bronchiectasis, the empirical antibiotic should consist of an anti-pseudomonal agent, and we should be guided by the previous culture reports and the sensitivity till the time we get the isolate in this particular exacerbation. So with this, we come to the end of this panel discussion on respiratory infections. What we have tried to do is that we have picked up some 5-6 sessions on infections that happened during the Varanasi Napcon. We try to incorporate those topics with real-life cases that was pertaining to this particular topics, and we have tried to discuss some of the important aspects, clinically relevant aspects. Of course, with some constraint of time, we have to shorten it. So I sincerely thank all the 3 panelists, Ashok sir, Dr. Yuvarajan, and Dr. Joydeep. Thank you so much, Ashok sir, Dr. Yuvarajan, and Dr. Joydeep once again. And I sincerely thank all of you for taking time off your busy schedule and educating the delegates on the subject with the lots of knowledge that you possess and immense experience that you have acquired. And we further thank the ICS office bearers and the Mankind Aspergillosis team for giving us this opportunity. And I'm told that we'll take the panel questions only after all the sessions are over. So I hand over the baton back to the moderator of the day, Dr. Rajadhar.
Thank you so much, Rajesh, and the rest of the panel. Let me finish off by introducing the third topic of the day, which is going to be a panel on sleep medicine. For this panel, the moderator for this session would be Dr. BP Singh. Dr. BP Singh is a reputed pulmonologist, and that's an understatement. He's one of the most busy and famous pulmonologists in the country. He is an MD and an FCCP, the director and president, Midland Healthcare and Research Center, and he established the Surya Foundation in 2006, a foundation which has been responsible for doing multiple cardio-respicon updates dating to 2022. I have been lucky enough to be a part of these meetings, and I have seen the amount of passion with which he holds these academic sessions, and the way he looks after his faculty and his delegates is exemplary and a learning experience for a lot of us. He's trained in sleep medicine from Medcare, Amsterdam, Holland. He's learned thoracoscopy from Marseille, EBUS from Singh Health, Duke, NUS, Singapore. He is the organizing secretary of the 4th ICDS CSM conference and is the current president of this august body. He has national and international fellowships from a lot of important organizations, international organizations. He's delivered multiple lectures and is really a sought-after faculty throughout the country. He also has multiple publications, but above all, Dr. BP Singh is a great human being. He's touched the lives of multiple patients throughout UP. He works extremely hard. He works into the wee hours of the night and starts every morning with the same amount of passion. I think we are lucky to have him on day 1 of Best of Napcon. And I leave it to Dr. Singh to introduce the rest of the faculty, the rest of his panelists to all of you. Over to you, Dr. Singh.
Hello and good evening, friends. It's a matter of privilege and honor to talk on this evening on a subject which is very common and involves a big population. As you all know that obstructive sleep apnea is a disease which affects around 1 billion population globally. Unfortunately, 80% of these patients are even in USA are not treated. So the things has not been improved, over the period of time in spite of so much advancement in the field of the sleep medicine. In the last 3 decades, there is a lot of advancement which has occurred in this branch, and over the period of time, new thought process and new concept has been emerging. The obstructive sleep apnea is basically, it is an increasingly common sleep-related breathing disorder characterized by repetitive upper airway narrowing, hypopnea, and closure during sleep. And this action causes intermittent hypoxemia, hypercapnia, and frequent cortical arousal. If left untreated, OSA can adversely affect the cardiovascular system, cause neurocognitive impairment and daytime sleepiness, and increase the risk of motor vehicle accidents. So in that way, it becomes very important to know. And it has got its own implications, and the cardiovascular disease implications has been one of the significant, along with other effects over the system. And obstructive sleep apnea has 3 components, as already mentioned: intrathoracic pressure swings, recurrent arousals, and intermittent hypoxia. And that leads to the changes into the cardiovascular system, causing problems. There are different clinical phases of obstructive sleep apnea. A cluster analysis has shown there are 3 subgroups of patients, especially the disturbed sleep group of insomnia related, that is 32.7. Another group was minimally symptomatic, 24.7. And third was the excessive daytime sleepiness, 42.6. So in that way, there are 3 subgroups. Another majority at all has explored this group into four one, and the disturbed sleep, the minimally symptomatic, and excessively sleepy, and the moderately sleepy. And what were the implications of it? The excessively sleepy subtype had increased prevalence of cardiovascular disease at baseline and a higher risk of incidence of recurrent cardiovascular events compared to the other symptom subtypes. Obstructive sleep apnea without obesity is common and difficult to treat. Evidence for a distinct pathophysiological phenotype has shown that around 20% of the patients of the adult OSA are non-obese. And non-obese patients with OSA have the higher risk of basically having hypertension, 4-fold rise, and odds of early atherosclerosis of 2.7-fold. In that way, it becomes a risky thing to have obstructive sleep apnea, even in the patient with the non-obese. OSA with comorbidities is dangerous lesion. I will just skip, and it has poor outcome. If you look at the causes of the OSA, there are different traits. Phenotypical traits are attributed, and these traits include the anatomical cause. They have the narrow or the crowded or the collapsible upper airway. Another is a non-anatomical cause. And the 3 important subclasses have been identified: that waking up too easily during airway narrowing, a low arousal threshold, ineffective or reduced pharyngeal dilator muscle activity during sleep, or the unstable ventilatory control or the high loop bone content. So in that way, there are 4 sub-variety, and the most important had been, you all know, that is the crowded upper airway, which is the important cause of the obstructive sleep apnea, which is as it is shown in this picture. Traditional treatment had been you have to approach this patient along with the weight loss and positional therapy. The CPAP, the oral appliances, and upper airway surgery has been the primary mode of treatment of obstructive sleep apnea. However, it has got different, basically the drawbacks, and because of this reason, almost 50% of the patients, they are not getting enough benefit with this treatment. I will not go into the detail. I'll just skip because of the paucity of time. Then question arises, actually, this is the standard treatment what we have been following. Does one size fits all? The recent evidence indicates that non-anatomical contributors play a prominent role in the pathogenesis of OSA for many patients, particularly in certain groups. Example is the non-obese OSA patients. Thus, new and emerging therapies that target a specific phenotype or treatable traits show promise as an alternative to traditional therapies that focus on the anatomical problem. It is time to review the traditional therapies and look for alternatives, and it is time for a tailor-made approach or individualized treatment for obstructive sleep apnea. Then what are the current treatments that target upper airway anatomy? and CPAP, as you all know, I will not go into the detail. The oral appliances, these are the mandibular advancement devices which are used in the management of the obstructive sleep apnea. Weight loss, everybody knows that is one of the important components in the management of the obstructive sleep apnea with the obesity, and excessive body weight more than 25 kg per square meter BMI is largely responsible for OSA, and 17% reduction in BMI significantly reduces the parapharyngeal fat of pads and increases the oropharyngeal volume and has a major beneficial effect on upper airway collapsibility. The positional therapy is also said to have important role in those patients, those who are having supine obstructive sleep apnea predominantly, and positional therapy has got its own role. Upper airway surgery has also been described as salvage therapy following failure of other treatment in the patient with obstructive sleep apnea. And it has got its own problems, and although it is a difficult one, and most of the time it is taken as the last resort. Then what are the non-anatomical contributors to OSA and the potential targeted therapy? In addition to the importance of the impaired upper airway anatomy to the pathogenesis of OSA, recent advances in OSA phenotyping and respiratory neurobiology have identified non-anatomical causes and novel targets for therapy. Approximately 70% of patients with OSA have impairment in one or more non-anatomical contributors. And this is the very important picture from the chest 2017, where they have shown very clearly there are four predominant phenotypes: the narrow, the crowded, collapsible upper airway. Another one is the low arousal threshold. The third one is the poor muscle responsiveness, and fourth one is basically unstable ventilatory control, the high loop gain. And low arousal threshold, basically the cortical arousal from the sleep during the obstructive event occur when increasing negative intrathoracic pressure reaches a certain threshold. That is the arousal threshold. Repetitive cycling between the wakefulness and sleep can destabilize breathing, prevents deep sleep, and perpetuate OSA severity. Evidence indicates that 30 to 50% of all patients with OSA and more than 85% of non-obese patients wake up too easily to a small change in intrathoracic pressure between 0 and minus 15 centimeter of water. And this action may also prevent adequate recruitment of upper airway muscles. And why arousal threshold is important in OSA? Because if the low threshold is there, patient will easily arouse them. If the high threshold is there, then patient will not be aroused very easily. And this is basically the cartoon. I will not go into the details. Actually, it has been shown that patients with low arousal threshold can be treated with sedatives. And these drugs that like trazolam, trazodone, zopiclone, and zopiclone, they all lead to the basically the low arousal threshold. They increase it, and that is how they decrease the AHI in these patients of the obstructive sleep apnea. And this is a study of the Danny Eckert, which shows that low arousal threshold, when you use the drug like zopiclone, you can see there is a drop in the AHI. And this is how the sedatives can be used in the treatment of OSA. If you look at the airway collapsibility, if it is high, then you have to use CPAP. If it is low or moderate, then use the, look at the dilator muscle function. If it is poor, again use the CPAP. If the dilator muscle function is good, look at the arousal threshold. If it is low or moderate, you can look at the ventilatory response to arousal, and then you can use the sedative. However, the arousal threshold is high, use CPAP. Here you will not use the sedative. Reason being that it might lead to the respiratory arrest, and patient will not respond to the treatment, and this becomes risky. So you have to identify the patient with the low arousal threshold should be given the sedative in the management of the obstructive sleep apnea. The reduced muscle activity, the pharyngeal muscles play a pivotal role in the maintenance of upper airway patency. And a state-dependent reduction in muscle activity and reflex control contribute to the upper airway collapsibility. More than 30% of patients with OSA have minimal muscle responsiveness to negative airway pressure during sleep, which is a key contributor to OSA pathogenesis. Conversely, excellent muscle responsiveness during sleep can protect certain individuals with pharyngeal and anatomical impairment from OSA. And this has been shown with the studies, those who have retained genioglossus muscle activity during the sleep, they will not have the obstructive sleep apnea in spite of the very negative pressure in the intrathoracic cavity. And what are the treatment? The hypoglossal nerve stimulation, the pharyngeal muscle training a newly evolving concept, the drugs in the management of this component. The hypoglossal nerve stimulation, they are useful, and they have basically stimulation of the hypoglossal nerve, which innervates the intrinsic and extrinsic muscles of the tongue and improves the upper airway patency during sleep. And that leads to sustained reduction in AHI more than 50% after 6 to 12 months and 36 months of follow-up. However, it has got its own limitation. Pharyngeal muscle training is also effective in few of the patients of the obstructive sleep apnea, where the muscle functions are poor. And basically the drugs, especially the desipramine, has been shown to be effective in improving the AHI in a select subgroup of patients where the muscle function is poor. However, in this cartoon, actually in this trial by Toronto, they have published this data that patients with OSA, desipramine has been responsible for reduction in AHI in a significant number of patients. Taking the cue from this drug, another trial was used by the atomoxetine, which is norepinephrine transporter, and 5-hydroxytryptamine transporter, and oxybutynin has the anti-muscarinic effect, and they led to this is significant drop in AHI in the patient of the obstructive sleep apnea, where it has improved the muscle function and prevented the airway collapse. And in this way, it led to the significant drop in the AHI by more than 50%. For the arousal threshold, I already mentioned that hypnotic agents can be used like the S-zopiclone, the zopiclone, or trazodone. They can be used for the patient with a low arousal threshold. Then coming to the very important component and very commonly talked about thing, that's the loop gain. It is a measure of the susceptibility of the periodic breathing. Loop gain is ventilatory response in relation to the ventilatory disturbance. And high loop gain is associated with the unstable system, and the low loop gain is the stable system. So you have to maintain basically decrease the high loop gain, and for this, the oxygen therapy and the carbonic anhydrase inhibitors have been found to be useful. And in this patient where the high loop gain is there, oxygen therapy reduces loop gain by approximately 50% and lowers AHI by approximately 50% in patient with OSA with high loop gain. However, it is not effective in everybody. And carbonic anhydrase inhibitors, the acetazolamide, it can also be used for reducing the loop gain. And in that way, it helps these patients. Our tolerance is the big issue with the carbonic anhydrase for the long term. And this is basically a study by the Edwards published in the Journal of Physiology in year 2012. And this gave the concept that acetazolamide can reduce the loop gain and improve the apnea-hypopnea index. So the schematic summary of the existing experimental targeted therapies to treat OSA is basically the anatomical therapies, the muscle function therapies, the loop gain therapies, and the arousal threshold therapies. Then comes the personalized approach, the PALM, the peak rate, arousal threshold, loop gain, and muscle responsiveness scale. And this is important actually, and most important thing is basically, if you look at the PALM scale, it is the anatomical impairment, which is most important. And studies have shown with a mild anatomical impairment, one or more targeted non-anatomical interventions are required. In the moderate anatomical impairment, where the peak rate value is -2 to +2, where if more than 64%, one or more non-anatomical impairments are there, that leads to the targeted anatomical and non-anatomical combination therapy is recommended. While 36% will not have any no non-major anatomical impairment, here the answer is one or more anatomical interventions like CPAP or mandibular advancement device. Where the severe anatomical impairment is there, where the peak is more than +2, the major anatomical intervention is required like the CPAP or the mandibular advancement or the surgical therapy. Now the concept has arisen that for the combination therapy, and I will not go into the detail, actually combination therapy like oxygen and S-zopiclone has shown that 40 to 50% responded to this approach in the treatment. So the future is that pathogenesis of sleep apnea, you have to combine the therapies to have the better effect. I will not go because time is very less, and personalized therapy is evolving, and their major obstacle to implementation of phenotyping concept into clinical care is that the current gold standard measurement techniques are too complex and not feasible beyond research. However, several recent studies have made substantial progress in the development of simplified phenotyping tools to advance tailored therapy. So Future is there that we have to personalize treatment according to the patient requirement. To conclude, there has been substantial recent progress towards personalized management of OSA, and based on the knowledge on the multiple causes of OSA, we have to identify the new therapeutic targets and promising proof of concept data for targeting therapies, including combination therapy and an ongoing development of simplified phenotypic tools to be used in the clinic to inform targeted therapies for OSA. This research has the potential to realign treatment and management approaches for this common chronic health condition. So with these words, I'd like to conclude here and thank you, all of you, thank all of you for the patient hearing. Thank you. Now, I will move on to the panel discussion. I think we can ask our panelists to join, and we have two panelists, very senior in the field of pulmonary medicine and the sleep. Those who have joined us today, I welcome all of you, Dr. Mahavir Modi and Dr. Shyamal Sarkar, for joining us. I'm thankful. And welcome, Dr. Modi and Dr. Sarkar. I will just introduce in a minute. Dr. Shyamal Sarkar is the Director of Advanced Chest Clinic and Sleep Apnea Center, Ranchi, and is Senior Consultant of Orchid Medical Care Center, Ranchi, and Chairman of ICS, Jharkhand. Dr. Modi is the Consultant Pulmonologist at Ruby Hall Clinic and Pune since last 18 years, and Director of Modi Clinic and Excellence in Chest and ENT, Pune, and Executive Management in Healthcare by University of Virginia, USA. He has done, as he won many awards. And I will not go into the further introduction. I will just move on to the panel discussion. So welcome, Dr. Modi and Dr. Sarkar.
Thank you, sir.
So this is a very important topic actually, and we all are struggling to get the optimum treatment and optimum management in our patients. So first question to Dr. Modi, what is the thing which determines the severity of OSA in the treatment?
Hello, and thank you, sir. It was a very lucid talk and a lot of new insights for basically about the phenotyping in patients with COPD. Just like we do phenotyping in asthma and in COPD, you are doing phenotyping in sleep medicine, which is really a need of our. About the determinants of OSA, so the severity of OSA, most of the times we find that more OSA is common in females, plus as the increasing age. Then we also see for certain markers like the patient, those who have large neck circumference with and patient those who are obese and hypertension. So I think this is the common category of patients where we tend to get more patients of obstructive sleep apnea. And severity of these patients we basically assess by doing the polysomnography, where we find out how much is the AHI, apnea hypopnea index, and any apnea hypopnea index which is more than 15 we calculate as more than 10 we calculate as severe OSA. And other determinants of severity of OSA, I think, is the clinical presentation, where the patient, those who feel a lot of metabolic comorbidities, as you have rightly mentioned in your talk. So the patient, those who are having, along with obesity, they have cardiac risk factors like ischemic heart disease. The patient, those who are hypertensive, plus this patient, those who are having type 2 diabetes mellitus. So all these patients are, I think, those who have metabolic comorbidities because of OSA, and they also fall into one of the classification for mentioning about the severity of OSA. So anything if you want to add? Yes.
No, excellent. And this is the reason actually you have to identify the severity of the OSA, and you can tailor your therapy according to that. Coming to the Dr. Sarkar, why some patients with OSA develop diurnal symptoms related to nocturnal sleep disorder breathing and others do not? Please unmute yourself, Dr. Sarkar.
Thank you. And first of all, I want to congratulate you for your excellent presentation and highlighting the importance of phenotyping in the OSA patient. And we have to go away from the all-side fixed-all type of diagnosis that treatment, and that is the most likely goal of your presentation. And regarding question, excessive daytime sleepiness is the most important considered symptom in the daytime symptoms in OSA patient, and we are using it as an important pointer for the diagnosis or prognostication as well as for treatment of this.
Yes, Very right.
Several population-based studies have shown that as high as to 25% of the patients of OSA, they don't have excessive daytime sleepiness. And many a times they are phenotyped as a non-sleepy OSA or OSA with no EDS. The basic cause identified for this excessive daytime sleepiness is the profound intermittent hypoxemia in these patients and the sleep fragmentation with consequent repeated arousal on which results in excessive daytime sleepiness. And it has been found that in patients with non-sleepy OSA, they have less evident this problem. That these two important complications are less evident in patients with a non-sleepy OSA. And most likely they are less susceptible because of their genetic factors. They have less susceptibility of the cortical effects of apnea. That's why they don't have so much sleep fragmentation and don't have excessive daytime sleep. Now, most likely this may be explanation from my side.
Very right. So we'll just move on to the next question to Dr. Modi. What are the non-anatomical contributors to OSA and potential targeted therapies? Be in short, Doctor.
So you have actually very beautifully explained about all non-anatomical contributors in patients
Dr. Modi.
with OSA.
Yes, yes. Please.
Can you hear me? Yeah. So basically,
yes.
These are, we all know that almost 70% of patients with OSA, they may be having more than one non-anatomical contributors. And most of the time, these non-anatomical contributors are basically, there are patients, those who are having lower arousal threshold. So these patients, they where the sleep can get disturbed because of any of the arousal, very low arousal threshold. And these candidates, they can be basically picked up for giving a very low dose of hypnotics and their sleep problems can be treated. Then we have patients, those who have high or the low ventilatory loop gain. So for example, patients, those who are having a high ventilatory loop gain, so these patients, they can be offered a treatment with oxygen. The patient, those who are having a low ventilatory loop gain, they can be tried with drugs like acetazolamide. So I think this is second category of non-anatomical variant. Then also we see patients, those who have a lot of decrease in the tone of the airway dilator muscles as well as the muscles like genioglossus. So these are the patients, those who can be targeted for the hypoglossal nerve stimulation. And I think there is one more category of patients which I think you mentioned, but I am just not able to recollect. But these are certain indices by which we should be able to know whether these are some non-anatomical variants for treating the patients for OSA.
Yes, very rightly you have mentioned. Actually, in the lab, these data has been just reported, and it is a complex research which is involved. So one methodology which has been developed, I'll just discuss later on. So I will move on to the Dr. Sarkar. What are the current trends that target the impaired upper airway anatomy? Dr. Sarkar.
The answer to this question will be like that. The non-anatomical component is the most important key pathophysiological mechanism, as we have discussed repeatedly. And basically, they come into two important categories, which is skeletal framework abnormality of the craniofacial abnormality, and which are considered to be the static component of the upper airway obstruction. And often they are genetically mediated, like hyponatremia or hypertropia, hypomaxilla, low hyoid bone, etc. And another important component is the abnormality of the soft tissue. And these are the most important consideration of the country, because these are the dynamic component of the upper airway obstruction related to enlarged and elongated uvula, palate, base of the tongue, lateral pharyngeal wall, and there are some nasal abnormalities. So treatment regarding this, CAP therapy is considered to be the gold standard for all sorts of problems. After diagnosis, it includes the CAP treatment, and it can be given with CPAP, APAP, and BiPAP regarding the different indications. As you know. But more than 50% of the patients often shows poor adherence to the CAP therapy. And here comes the problem. When the CAP therapy tells what to do. So here again, we have to sort out the non-CPAP therapy. Non-CPAP therapy, either surgical or not surgical. The surgical component again, as we told in obese patients, reduction in the weight is the most important step, which is always in all the patients we have to think about reduction of the weight with the help of diet, with the help of exercise, with use of some pharmaceutical agent, and in severe cases, the surgery. And positional therapy is again non-surgical, and it has been found that positional therapy, particularly in patients with predominant OSA, supine OSA. Now it is called individual OSA, individualized patient with OSA. So this definition is now, if we find obstructive apnea, so in the more than half of the patients, more than half of the obstruction are, let's say, in the supine position, these are quite predominant. But now these are they are called individuals predominant supine. Predominant supine means that the age apneas less than 5%, pathological apnea less than 5%, then it is called individualized OSA, supine OSA. So here the positional therapy, as we know, therapy, or nowadays there are lots of improvised technique therapy device which prevent the supine position. And then comes the role of oral appliances, mandibular advancement therapy, advancement devices or tongue retaining devices that push the jaw forward and push the tongue forward and increase the caliper and thereby decrease the collapse. So these are the non-surgical options for the pericardial patients. And the surgical options according to the site of the obstruction, whether it is problem in the nasal cavity or problem retropalatal or retroglossal, which has to be identified clearly by the DICE, that is drug-induced sleep endoscopy test, which is basically done by the specialist. And after recognizing the particular site of obstruction, because multiple level of obstruction can be found in there, and then the specific site of obstruction can be done. Most importantly, you will have laryngoplasty, different types of radiofrequency ablation, and these are the surgical process. And again, the majority of the mandible and enlargement device, and then these are the sorts of the surgical therapy. So these are the way I think.
Yes, Dr. Sarkar, you have very nicely elaborated all these things. I will just, because for shortage of time, now there is a novel method to quantify the pathophysiological traits by polysomnography.
Yeah. So again, basically, because as you said rightly that the one size doesn't fit all, so CPAP cannot be the treatment of choice for all patients with OSA. And that is the reason that we want to find out what can be the pathophysiology behind this OSA. And for knowing this pathophysiology, there is a very novel method. And this method says that first is one has to estimate the arousal threshold, and it can be done based on the median value of the ventilatory drive. And this should be done immediately following the scoring of the EEG arousals. So once we do that, then the breath by breath phenotype plotting of this ventilation versus the ventilatory drive. And so this can be then sorted out to 10 beans. And then these data can be used to find out whether the patient has V passive or V active. So V passive means the patient, those who are having median ventilation at the eupnic threshold. And the second is V active is the median value of ventilation at the arousal threshold. So once we know what is the arousal threshold and what is their median value of ventilation at this arousal threshold, or the median value of the ventilation at the eupnic ventilatory drive. So based upon these two, we should be able to know what is the actual pathophysiological trait for these patients with OSA, and then we can categorize these patients, and then based upon that, we can decide which kind of therapy is going to be useful in these particular patients.
Very rightly mentioned, Dr. Modi. Actually, it is just an evolving concept. By looking at the polysomnography itself, you can identify what type of basically the phenotypic patient of OSA it is. So this is how the things are evolving. We probably will look at more at this data and detail, and will our understanding will improve over the period of time. And just one question: what is the to Dr. Sarkar? What is the differential diagnosis of daytime hypersomnolence? Dr. Sarkar.
Yes.
What is the differential diagnosis for the hypersomnolence? Just give it. Apart from the obstructive sleep apnea.
The daytime hypersomnolence actually is a sleep disorder, in which the most important component is excessive daytime sleeping. And this actually there are lots of several causes of this excessive daytime sleepiness. It comes into under 4 broad classes. The initial is the insufficient sleep. Is very common, either because of self-intention or because of some work or some unavoidable circumstances. The patient has less sleep, inadequate sleep. That is the most important cause. And there are certain drugs as well which can result in daytime sleepiness, certain benzodiazepines or non-benzodiazepines, opiate analgesics, some anticonvulsants, antipsychotic drugs. So here is an important point. And then comes certain medical problems or certain psychiatric or some neurological disorders that can also present with the excessive daytime sleepiness. And then sleep disorders, other than the obstructive sleep, sleep-related breathing disorder, as we are discussing today, obesity, hypertension syndrome, or periodic movement disorder, or circadian sleep disorders, or the central hypersomnolence, central disorders related to hypersomnolence like narcolepsy or idiopathic hypersomnolence. These are. So basically, drugs, basically the medical or psychiatric complaints or sleep disorder and insufficient sleep. These are the more common groups of the have to sort out the history taking, detailed history taking of the sleep and drug history, psychiatric history, or we can objectively and subjectively evaluate the patient with aqueous sleepiness scale or polysomnography if it is needed, or home-based polysomnography. That's an alternative way, or more sophisticated ways like MSLP or PWP. And these are the evaluations. But most importantly, excessive daytime sleep has an important consideration, particularly in relation to driving safety and the safety of the other population.
So I think now we have come to the end of this panel discussion. I'd like to thank the eminent panelists for their important deliberations, Dr. Mahavir Modi and Dr. Shyamal Sarkar, for the excellent conversation and excellent thought process to evolve and to have the clarity of the message while we are dealing with different aspects of the obstructive sleep apnea. As we all know that obstructive sleep apnea was already mentioned in the initial part, very common disorder worldwide, more than 1 billion population basically is having, patients are having worldwide, but unfortunately most are not diagnosed and unfortunately even lesser number are treated. Because of lot many things, actually we had the approach of once the diagnosis there that everybody was treated with CPAP and weight reduction. Unfortunately, the phenotypic traits has lately been identified. Still, it is in the research process, and most of the things are not easily identifiable at the clinical ground. However, new data is emerging, and we are looking towards it with much more optimism than before. And we hope that in the near future, we will be able to give personalized treatment to our patients with obstructive sleep apnea to have best results. With these words, I'd like to conclude here and thank all of you for the patient hearing. Thank you.
Thank you. Thank you, sir.
I would immensely like to thank hello everybody, I'm back again. I would like to immensely thank Dr. VP Singh for this excellent deliberation on sleep medicine. Everything that was really important that would help us clinically was beautifully covered by him. And I would also like to be highly grateful to my two dear friends, the two panelists, Dr. Mahavir Modi and Dr. Shyamal Sarkar, who did an excellent job. Dr. VP Singh, thank you very much for your excellent moderation of the panel. And I'm very happy to see Dr. Rajesh also over here, who also did a fantastic job of pulmonary infections. We have many questions from the audience, and I would like to take the questions from them. So I think I'll just go in around to make sure that all of us are included. So the first question is on TB, and it's a very interesting question which has been asked. Just a minute. Yes, there's a very interesting question by Dr. Mukul Saini, Pune, and it's very important clinically. So he's asking what is the difference between pyrosequencing and whole genome sequencing. And he also wants me to say something about the CBNAT XDR, which will be introduced soon. So I would like to say that this is a fantastic question. So pyrosequencing currently is what we have is the best in our country, which is actually pyrosequencing tells you about sensitivity. We have two types of pyrosequencing MDR and pyrosequencing XDR. It's available in Hinduja Hospital in Mumbai. And I think in Maharashtra, this is the only place where it's available. So as the name suggests, pyrosequencing MDR tells us about the sensitivity resistance to INH and rifampicin. So for rifampicin, it tells us about the RPOB mutation, just like all the other molecular tests like LPA and CBNAT tell us. And for INH, it looks at the same two mutations like LPA, which are the CATG gene and the INH-A gene. So that is about the pyrosequencing MDR. And pyrosequencing XDR tells us about the sensitivity to, about the resistance to INH, rifampicin, quinolones, and injectable aminoglycosides, exactly what LPA does. But the role of pyrosequencing is that it tells you when there is concordance or disconcordance between phenotypic and genotypic sensitivity. So, sometimes you have silent mutations which are present. They will not give rise to any clinical resistance, but the LPA or CBNAT will diagnose it as false resistance. So pyrosequencing will tell you whether this mutation is silent or not and whether it's clinically important mutation. So pyrosequencing tells you about the resistance to various drugs, which LPA tells you, but it also tells us if clinically this is an important mutation or not. So that is how pyrosequencing is important. Whole genome sequencing is the best. It's the gold standard for diagnosing TB. And in fact, a lot of countries in the world like Belgium, they only use whole genome sequencing. They've actually given up midgets. But in India, as of now, still it is not recognized. It's being done in Hinduja and also in Bangalore. But and also 1-2 labs do it, but it's still not accepted. So whole genome sequencing will tell us about every possible mutation to TB. So that is the best. It's like a directory which tells you about every possible mutation. So that is the advantage of whole genome sequencing. And talking about CBNAT XDR, so CBNAT XDR tells us about resistance to INH, quinolones, and second line aminoglycosides, which are amikacin, capromycin, and kanamycin. The result is available in 2 hours. And basically, just like CBNAT, the load of TB germs have to be 133 bacilli per ml of specimen. But the thing is, it will not tell you about rifampicin resistance. So the patient has to be rifampicin. You have to first find out about rifampicin by doing CBNAT. And after that, you do Gene Expert XDR, and it gives you the result in 2 hours. It's already available in Mumbai. We are doing it since more than 6 months. Hinduja does it. And we've also compared it with LPA and pyrosequencing and also the midget sensitivity. And it's extremely comparable with excellent sensitivity and specificity of the order of 90% and more. Okay, so now I'd like to go to something different. So I'm going to ask Dr. Rajesh, there's a question for you from Dr. Anu Varghese. He's saying that CT scan is showing bilateral consolidation with Bal galactomannan positive fungal culture as Candida. What will be the line of management?
Good evening, ma'am, and very nice to see you, ma'am.
Same here.
Divided by distance, but united by all this meetings. Meetings. Thanks a lot, ma'am.
Yes.
So the question from Dr. Anu was that Bal galactomannan is positive, but then the isolate is Candida. I will put it across this way that usually airway Candida is almost always a colonizer. Usually we don't treat it. So if you are suspecting Aspergillosis, invasive pulmonary Aspergillosis, and you have some evidence of that other than you have risk factors, you have evidence other than the bad galactomannan alone, probably you go ahead and treat it. But just for an airway Candida, it's probably a colonizer, probably just leave it alone. Unless, of course, you have multiple site Candida isolation in a patient with high risk factor for invasive candidiasis. Am I correct, ma'am? Ma'am, I think you are muted.
Sorry, yeah, I'm sorry. No, I completely agree with you. Very well answered. Absolutely. Completely agree. I'd like to come to Dr. VP Singh. A very interesting question from Kota. When do you want to think about non-CPAP therapy for a patient of obstructive sleep apnea?
Good evening to all of you. First of all, I like to say, and basically non-CPAP therapy, as already we have mentioned in our presentation also, CPAP therapy may be an answer for those patients, those who are having non-anatomical form of obstructive sleep apnea, where the low arousal threshold is there. You can have this basically the sedative drug. You can have non-CPAP therapy for even those patients who are having the anatomical abnormality, where the mandibular advancement device can be given. Patient can have positional therapy, basically the speech therapy. So all these things can be offered to the patient. Those who do not tolerate CPAP, if they are candidate for it, if they are basically patient is having mild obstructive sleep apnea, then these patients can be given this type of therapy. Those who have non-anatomical component, their other therapies can also be offered, like as already mentioned, that for especially that group of the low arousal threshold, where the sedatives can help a lot. And those patients who are having basically higher loop gain, although it is very difficult to identify these patients, those who are having higher loop gain, where oxygen therapy can be supplemented and even acetazolamide can be given. So all these things can be given depending upon which type of the phenotype patient is having in the obstructive sleep apnea. Ideally, CPAP is the gold standard for all these patients, apart from the weight reduction, and along with that those patients who have the intolerance to the CPAP, then they can be advised with the mandibular advancement devices. It may be tongue retaining device or any other thing. Or nowadays, hypoglycemic nerve stimulation has also been tried in the Western world with the variable results, but not in India. We do not have this facility. And surgical answers are there when the patients are as a salvage therapy, where all these patients, they do not tolerate the CPAP. So all these things can be offered those who do not use the CPAP.
Thank you very much, Dr. BP Singh. Or as always, you were absolutely perfect in giving us the answer. Now I'll take two TB questions together. Very interesting questions are coming up from the audience, and thank you so much, dear audience, for being so active and asking us questions and making us feel good. So there are two questions. One is by Dr. K.L. Prajapati from Indore, who's asking, what is the role of steroids in miliary TB? And there's again a very nice question from Dr. Deep Kothari from Ahmedabad. Is there any role of steroids in TB and HIV? So I'll take both these questions together. So first, Dr. Prajapati's question, role of steroids in miliary TB. So this is an excellent question. So when we were students, we were told that miliary TB, you have to use steroids with AKT, but science has changed and we have a lot of evidence. So miliary TB patient does not routinely require steroids. We are just supposed to give standard AKT in the correct doses after knowing what is the sensitivity, resistance pattern to rifampicin INH. And basically, there are only 3 indications of using steroids in miliary TB. So often a patient of miliary TB can have CNS TB. So the thing is that even if the patients don't have symptoms, if the patient has miliary TB, please do an MRI brain. And if the patient has meningitis, patients have tuberculosis with lesional edema, then this becomes mandatory to use steroids, and we'll end up using DEXA. The doses had been put up. We'll be using 0.3 mg per kg per day for the first week, 0.2 mg per kg per day for the second week, 0.1 mg per kg per day for the third week, and then 3 mg per day, fourth week, 2 mg per day, fifth week, and 1 mg per day, sixth week. So the first indication of steroids in miliary TB is presence of CNS TB. Even if patient does not have symptoms, please do MRI brain with contrast, because if you just start AKT, then the patient has a paradoxical reaction in the brain and the condition may go bad. The second indication of using steroids in miliary TB is often these people have adrenal TB. So just like dissemination takes place, the adrenal gland gets involved, and basically the patients are somehow managing with the reduced steroid levels which the adrenal is producing. But after we start AKT, we know rifampicin will make the steroid dose half, and therefore initially when there was adrenal gland insufficiency, after starting AKT, especially rifampicin, the patient will go into adrenal crisis, and this patient may actually collapse, requiring ventilatory management, inotropes, etc. So please do serum cortisol levels of the patient before starting AKT, and if the levels are normal, then start. If the levels are abnormal, you have to start steroids. And over here, if the patient is unwell, we give hydrocortisone 100 milligrams a day, and as maintenance therapy, we give 50 milligrams a day of prednisolone. Also, if the patient's cortisol levels are normal, but on imaging, if the adrenal gland is involved, then either you can do ACTH stimulation test, the selectin test, or you can actually start AKT without steroids. And on the 4th day, please check the cortisol levels, because sometimes after that the cortisol levels may go low. So second indication of giving steroids in biliary TB is presence of adrenal TB, and you can always do imaging and find out. And the third indication is that uncommonly but possibly TB can present as acute presentation in the lungs, and sometimes biliary TB can also present as respiratory failure, ARDS. So this is the time we need to give steroids. We prefer to give methylprednisolone 40 milligram BD to TDS based on the weight of the patient. So these are the 3 indications of use of steroids in biliary TB. I'll respond. Now I'll take another question, and I'll go to non-TB and take the second question, because I think this answer became a little long. So now I'm going to go to Dr. Rajesh. Just a minute, there are just so many questions I'm looking around. So Dr. Rajesh, just one more question from Dr. Anu Varghese from Palakkad. He already asked one question to you. So is there any preference between tazobactam and avibactam?
Madam, for routine lung infections, we prefer piperacillin tazobactam, especially as a good anti-pseudomonal cover and such stuff. But whereas when we are suspecting something like a carbapenem resistance, especially the KPCs, if the Klebsiella pneumonia carbapenemases are the one that are responsible for carbapenem resistance, then definitely ceftazidime avibactam will be a upfront choice. And again, in India, we don't have much KPCs. The most carbapenem resistances are coming from the OXAs, like the NDMs and new Delhi metallo-beta-lactamases and such stuff, in which case a combination of ceftazidime avibactam plus aztreonam would be a preferred upfront choice with whatever gadgets are available within us. So I would just put it across that a routine patient, you are fair enough going ahead with a tazobactam combination with a beta-lactam. Whereas if you are suspecting carbapenem resistance, definitely avibactam is the agent that actually is preferred upfront.
Yeah, I completely agree with you. And especially sometimes we are pushed in situations where there's carbapenem resistance, and often polymyxin has failed, and in that case, probably using avibactam with ceftazidime will be the best choice, because we probably not have anything much. And of course, we add aztreonam, like Dr. Rajesh rightly told us. Thank you, Dr. Rajesh, for this correct answer. And thank you, Dr. Anu Varghese, for this important clinical question that we all face day to day. Now, there's a nice question for Dr. BP Singh. Dr. Deep Kothari from Ahmedabad is asking, can we use melatonin in OSA? And when would you use it?
Melatonin.
Okay, yeah.
Hello. Can you hear me? In OSA, melatonin as a treatment has not been recommended because, yes, for the, as I already mentioned, for the patient with the low arousal threshold, where you can identify these patients where the hypnotic, basically the sedatives can be used, but the trial is with drug like S-epizoclone or zolpidem or trazodone or temozepam. So all these drugs have been tried, but I do not, actually, I'm not aware of the use of melatonin in this condition, how it can be used. So melatonin is predominantly used in the, basically the circadian rhythm disorder, but not in the obstructive sleep apnea, as far as I know.
Can I just add something?
Yes, definitely.
Actually, the thing is, there are certain patients who, despite using CPAP, despite using it properly, or maybe they don't use it very well, they use it only partially, but these patients still complain of daytime drowsiness. So for these people, melatonin, oh, I'm sorry, yeah. Okay, yeah. No, so actually the thing is, in patients with melatonin, we can use the OSA, especially the patient is using CPAP. And if they have a problem with sleep initiation, then melatonin can be given to them for the reason of sleep initiation.
Only thing is that, yes, for this, that is how basically these recommendation has come up for the phenotyping. Actually, you have to identify which patient you are dealing. Where the arousability is low, the sedatives are recommended. But I have not come across any study with the melatonin, although it might be there. And actually, low arousal threshold you can identify while you are doing the sleep titration. If the CPAP pressure requirement is around 6, or patient is having predominantly hypoapnea, these patients are easily arousable, a low arousal threshold. Clinically, these patients can be treated with a low dose of basically the sedatives, especially the zolpidem or azapiclone, for reducing their AHI, and they can be cured of these things in 50% of the patients.
Yeah, you're actually correct. I completely agree with you that zolpidem will be the complete sedative of choice, because it will not affect the sleep pattern, or it will not affect the collapsibility of the oropharynx. So, right. So I'll go back to the question that was asked to me about the role of steroids in HIV. So HIV and TB, a patient of HIV TB, if we have to start AKT for this patient, what is the role of steroids? So this is again a very, very important question which clinically we see. So basically the thing is, with HIV patients, there's a higher chance of paradoxical reaction. And in HIV TB, we have two types of paradoxical reaction. The first one is the normal paradoxical reaction, in which we have started AKT for the patient has clinically got better. And then when we introduce antiretrovirals for the patient, these patients present with fever, or the cough gets worse, or X-ray gets worse, they get lymph nodes, they get pleural effusion. So that is one. And the other one is known as unmasking paradoxical reaction, in which the patient basically has no symptoms of TB, and you find him to be HIV positive, and you start antiretroviral therapy for him. And after antiretroviral therapy, actually his immunity will get better, and now he will present with TB symptoms. So TB was always present in these people, but they were so immunologically naive that they could not give any symptoms. So this is known as unmasking iris in patients of HIV and TB. So the thing is that both these patients are going to present with fever, cough, pleural effusions, lymph nodes which are increasing, and worsening chest shadows. But basically it has been found that the unmasking paradoxical reaction, where TB symptoms are initially not present and then they came up, these are the ones who present very, very severely, and the inflammation is extreme. So over here, using steroids becomes almost mandatory. And basically the steroids of choice is prednisolone, and 1.5 milligrams per kg per day is given for 3 to 4 weeks. And this is if they are on rifampicin, because rifampicin will reduce the dose of steroids. If the patient is resistant, and if you're going to not give rifampicin, then the dose will be 0.75 mg per kg and be tapered over 3 to 4 weeks. After this, I'd like to again go to Dr. Rajesh, because there are many questions for him. So Dr. Vamshi Bangalore is asking him PCP prophylaxis indications and dose.
I think, ma'am, PCP prophylaxis, there are very well-defined conditions where the patient is at high risk for getting pneumocystis cavernae pneumonia. The important ones in our practice would be long-term steroid treatment, especially at a dose that is greater than 7.5 milligram of prednisolone or equivalent per day for a period of more than 2 or 3 weeks. And definitely when it goes to months, as in the case of ILD or steroid-dependent asthma, definitely that will be one of the commonest indications in our practice. Other than that, patients on chemotherapy who are otherwise immunocompromised, HIV, or with a CD4 count of less than 200, this would be some of the common indications for pneumocystis jirovecii prophylaxis. And if the patient is not allergic to cotrimoxazole, then cotrimoxazole would be a upfront preferred agent. The dose would be double strength, that is 800 and 160 of sulfamethoxazole and trimethoprim. One tablet 3 times a week would be a reasonable dose that we can give. In someone who is allergic to cotrimoxazole, there are many options, including inhaled phenamidine and all those things, which is a less preferred option now. Maybe we are, comfortable enough going ahead with a combination of pyrimethamine, sulfadoxine, or something like that, or even atavacone, like that.
Perfect. Very good. So this is what the PCP prophylaxis indications and the dose. Great. Now there's a very difficult question for Dr. B.P. Singh. This is really difficult. Dr. Bukul Saini Pune is asking, can you explain high loop gain and low loop gain in brief, please? I'd like to know myself because I get very confused here. Sir, can you please unmute yourself?
Thank you, Dr. Amita. Actually, yes. Basically, the loop gain term has taken from the engineering, actually, and where the plant gain and this all basically has been incorporated in this concept. The basic thing is here in the loop gain, there is a ventilatory disturbance, and to this ventilatory disturbance, there is a ventilatory response. And the ratio of this ventilatory response to the ventilatory disturbance is known as the loop gain. Simple. Where, for example, if a patient is having a hypopnea, there is a rise in the CO2. And this CO2 rise will lead to the chemoreceptor sensitization and causing increase in the ventilation. And this ratio, when it gets disturbed, it leads to the basically hyper response in the form of hyperventilation, causing loss of this PCO2, and again this PCO2 goes down, and this is how the chain stroke breathing starts in the central sleep apnea, whether classically the loop gain is there. However, in 30% patient of the obstructive sleep apnea, they also have the same thing. They also have the similar phenomena of the hyper responsiveness to the change in the PCO2, leading to the higher ventilatory response. And this basically leads to the unstable ventilatory center. And this is why it is required that you should identify the patient with a high loop gain, where the therapy oxygen is required. You can add even acetazolamide to these patients, but unfortunately, still it is a lot of research is going on, and it is difficult to identify clinically these patients. However, paper is there with basically Dr. Sand group in American Journal of Respiratory Critical Care Medicine 2018. They have tried to identify with the polysomnography that you can identify these patients with the high loop gain. However, still it is in the development. Not much clinically can be done, but you must know that this is what the concept is and that is what the reason is. So it is the ventilatory disturbance in response to the ventilatory response in response to the ventilatory disturbance. There is a change in the PCO2, there is change in the ventilation. So this is how the loop gain occurs. I think, are you able to understand it or not?
I completely understood. So I'm sure others must have understood. So thank you very much. You want to add something? Otherwise, you were very, very clear. Do you want to add
so that is what actually in the central sleep apnea, it is a very routine phenomenon. But in the obstructive sleep apnea, this also starts. It happens in around 30% of the patient. It has been identified with the research. So we need to know exactly, and in this subgroup of patient where you may need to add oxygen as a supplementation therapy or the Diamox for the long term. That is what I wanted to add.
Yeah, thank you. This was very, very clear. Thank you. You made something very difficult, very, very easy for us to understand. Thank you. Again, I'll take TB questions. In fact, there are TB questions are far too many, and I'm feeling very happy about it. I'm going to again mix two questions. Very good questions by everybody. So there's a question from Dr. Atul Francis, who's asking, what is the role of steroids in TB pleural effusion to reduce the pleurisy? And there's a very interesting question from Dr. Govind Desai, who's saying that normally we say pleural effusion is because of hypersensitive reaction to TB antigen, but Gene Expert Ultra are actually showing MTB detection in pleural fluid. So is it really hypersensitive reaction? So I'll take both these questions together. First, Dr. Atul Francis's question, role of steroids in pleural TB. So this is a very important and a very useful question, because when patients have pleural effusion, they are coughing a lot, they have fever, they have pleuritic chest pain. So if you want to add steroids, they get happier much faster. And therefore, less problem for us. But the thing is that we don't want to only make patients happy. We want to be very scientific. And we have multiple trials which have been done. And the trials have shown that if we are giving the correct AKT, means if the patient is having susceptible TB and you're giving correct AKT, the correct dose, the correct regime, then the thing is that you don't really require to give steroids to the patients. When you diagnose the pleural effusion, at that time, please do therapeutic tapping. Just don't do diagnostic tapping. If the patient has 2 liters of fluid, you can remove 1 liter on the first day. And second day, you please remove the other liter also. But please, you should ideally do therapeutic pleural tap and you give the correct AKT. So even if you don't give steroids to the patients, then at the end of treatment and long term, the chest X-ray looks the same. The amount of pleural thickening is the same, whether the patient received steroids or did not receive. And also on PFT, the FVC is the same in both the groups. So basically, routinely, we don't need to use steroids in pleural TB. However, sometimes because of hypersensitivity reaction, you start AKT in correct dose, sensitive TB, but the pleural effusion may keep on refilling. So we keep on aspirating the fluid again and again. Very often patients don't want a pigtail. Obviously, we don't really want to put an ICD in pleural effusion. because of TB. So sometimes people just get tired of aspirating the fluid again and again. Patients are not happy. In that case, we could give small dose steroids for about 4 weeks or something. That is the only role of steroids in pleural TB. We are not supposed to routinely give it from day one because it does not help at all. Long term, of course, patient symptoms go faster, but we would not want to take steroids if we had pleural effusion just to get rid of the symptoms faster. And the second question of Dr. Govindesa is very interesting, that when TB pleural effusion is a hypersensitive reaction, then why are we getting TB detected on a CBNAT ultra? So basically the thing is that commonly it's a hypersensitive reaction, but sometimes there's also a rupture of subpleural pulmonary focus into the pleura, and then you get TB. So when there's actual rupture, in that case, there is actual infection of the pleura, and therefore you can get TB. And sometimes if there's disseminated TB, and if it reaches the pleura that way. So when TB it actually affects the pleura, at that time, you will still get CBNAT ultra showing TB germs. So most of the time it's hypersensitive reaction, but in some people it can actually be infection of the pleura. So I hope I've answered the questions. Okay, so now I go to Dr. Rajesh. The questions are just increasing and I'm wondering how we're going to finish. So I think last question for you and one more question for Dr. BP Singh, and I think I'll stop because we've already exceeded the time. So just a minute, there are just so many interesting questions. I'll take this one. Dr. Nina P.S. Trivandrum is asking, what is the role of inhaled antibiotics in bronchiectasis and what would be the duration?
Thank you, ma'am, for that very interesting question. In fact, that probably requires a bit than the to inhaled and bronchiectasis. We can do inhaled antibiotics as an adjunct to systemic therapy during an acute infective exacerbation. Here, I think the duration is pretty clear, at least 2 weeks of systemic therapy. So along with that, you actually take inhaled antibiotics also for a minimum of 10 to 14 days. So that's the easily describable part. The second aspect, eradication of colonization. So we know that airway colonization by Pseudomonas and other potentially pathogenic microorganisms has a big role to play in the progression and prognosis of bronchiectasis, which actually is defined by the presence or isolation of Pseudomonas or any other PPMs on at least 3 occasions, at least 3 months apart, when the patient is not in an exacerbation. So once that happens, we know that the frequency of exacerbations, the accelerated decline in lung function, the hospitalizations, and even the mortality to some extent is worsened by the presence of the chronic airway colonization. In such cases, we aim at eradication therapy for this potentially pathogenic microorganisms via various regimes. And here, one of those regimes would be aerosolized antimicrobial route because of the ease to administer and the lesser toxicity. And this can be administered at a domiciliary level. Multiple agents have been tried and multiple durations have been tried. So we are not very clear because the duration has been as small as 2 weeks to as high as almost 48 to 52 weeks. So as a general consensus, a 3-month therapy with an agent would be a reasonable call on that. However, there are evidences and studies which have looked at 14 days and 14 days off, again 14 days on and 14 days off, like that, even 28 days on and 28 days off. So a lot of regimes. So it depends upon the individual patient that you are looking at and the results that you obtain, whether your therapy is actually achieving eradication. So that much about the duration. And regarding the agents, there are equally number of agents that have actually been tried. If you are looking at the ERS guidelines, then probably they recommend tobramycin as an upfront agent, whereas the BTS 2019 guidelines recommend colistin as an upfront agent for aerosolized route. We don't have aerosolized ciprofloxacin or aztreonam, but these are available and have been used in various studies across the world. So in our part of the world, probably what we can do is try up with a aerosolized tobramycin or a colistin as an upfront agent and use it as an individualized regimen. Probably start off with 28 days on and 28 days off until the time you achieve bacterial eradication in a patient while he is not in an exacerbation. If that fails and patient has recurrent exacerbations, then probably go ahead with a macrolide with an nebulized antibiotic. And if again the patient is having 3 to 5 exacerbations per year, despite these things, then think of periodic intravenous antimicrobial agents to sensitive bugs. I think I have been a bit long, but I think it required that.
Yeah, it was long, but much shorter than the answers that I've been giving. I think I've been just giving so many long answers. No, this was very, very concise and you made it very, very clear. Thank you, Dr. Rajesh. There are just so many questions that I'm going to just tell people to message you, so because there are just so many other questions here. I'm going to ask this question to Dr. BP Singh. In fact, every question from the audience is so nice, and then I'm just going to take the names of the people who ask questions and they can just get in touch with us because I think we are a little bit, we've overstepped the time. So for Dr. BP Singh, we have Dr. Rakhi who's asking, Dr. Rakhi from Baroda. She's asking that very often people who have sleep apnea, after it's diagnosed, they are only given auto CPAP at home to try for 7-10 days. And then they are saying, start using it. Is that how we should be ideally doing it? I think this is a superb question.
Yes. Thank you, Dr. Rakhi, for asking this very practical question. Actually, as a sleep specialist, we do not advise this thing to happen. Ideally, all these patients should be tested in the lab and the individualized CPAP pressure should be given to these patients. Auto CPAP titration can be done. Yes, it can be done, but usually it should be done in the lab if it is done, and that to be a sleep certified. In the Western world, it is recommended, but in our country, patient should be properly, a technician or the person who is doing the sleep study, they should be properly trained to look into it. The auto CPAP titration, yes, it can be useful, but many a times it is cumbersome in the way that it does not give you a very correct idea of the CPAP, whether all these phenomena are basically disappearing of the obstructive sleep apnea or not with the use of the auto CPAP while you are doing at home, whether the patient is comfortable, all the AHI has been corrected, whether in every position. You have to see this practically into the lab, ideally. Although, yes, if you do not have the facility in the lab, you can do it in the basically at patient's home, where minimum treatment can be offered to the patient. But ideally, even today in the Western world, in the US, the practices that ask these patients to come into the lab and get the sleep titration done properly by the sleep technician. And you can have a very precise answer to this obstructive sleep apnea, what pressure will be required to optimize your level of the treatment. Means your AHI should be less, your all the basic oxygen desaturation should be less, because you do not know in the home setting whether oxygen desaturation is corrected or not properly with the use of auto CPAP only. So you need to correct it here in the lab just to see properly where that patient is properly titrated. So in that way, yes, it can be done where the facilities are not there, but ideally it should be done in the lab.
Yeah, I'm so happy because now the master has told us, and I totally agree with Dr. BP Singh. It is really not correct to tell the patient that just use auto CPAP at home for 5 days and then we just take out the data and we tell them what pressures to use. This is really not okay because often we end up giving higher pressures, etc. So thank you. You made it really clear, and I am sure none of the pulmonologists have been doing this. It's probably medicine people, etc., might be doing this. I'll just quickly take 2 very small questions. There's Dr. Vidit Saxena who's asking me what is the interaction between steroids and rifampicin. So this is an excellent question. I want everybody to know that rifampicin makes steroids availability reduced by 40 to 60%. And therefore, if the patient is on rifampicin, we have to double the dose of steroids. So if the patient requires 30 milligrams of Isolone, please give 60 milligrams of Isolone, and we cannot forget this. And thank you, Dr. Vidit, for asking this question. And there's Dr. Ranganath teaching who's asked a very nice question. He's from Raipur. He's asked that, after we give the patient 6 months of AKT, the lymph nodes are still existing. So for how long should we be continuing the treatment? So this is an important thing that we always face in our practice. So the thing is that I basically, whenever it's lymph node TB, I make it a point to, before starting treatment, I always confirm the resistance patterns, because we know that lymph node TB often increase in size during treatment, and even after stopping treatment, new lymph nodes come up in the same spot or other spots. So it's always important. So anyhow, before starting treatment, if the patient's lymph node have passed as per the pass, then please do your rapid molecular testing to know what is the sensitivity pattern. If the patient does not have any pus, then you can actually do a USG guided biopsy of the lymph node, or you can do actually lymph node excision. But before starting treatment, please find out what is the pattern of rifampicin resistance. In Bombay, once we know the rifampicin resistance, though the program does not say, we always do either LPA or we do expert XDR to know what is the INH sensitivity pattern. So basically, this is really important. And once you know that the patient is definitely rifampicin susceptible and hopefully even INH susceptible, then you can actually stop treatment at the 6 months. As a rule, this is what I do for any kind of TB, even if susceptible TB, I give 9 months of treatment, because the data has shown that with 6 months of treatment, the relapse rate is 2%, whereas with 9 months of treatment, the relapse rate is 1%. So when we make a program, 2% to 1% is not statistically significant. But when we are talking patient to patient, if I were the patient, 2% to 1% to me is a huge difference. So at the end of 6 months, I tell my patients, ideally I should be stopping treatment. But if I were you, I'll take 3 more months. So just to answer your question, I would anyways give 9 months of treatment to a patient who's HNR sensitive. And at the end of 9 months, if the patient has responded well, he does not have any symptoms, etc., I tell him that let the lymph node be, you don't really have to worry. If the patients are really worried about wanting to continue treatment, then I actually tell them that if we are so worried, then actually excise the lymph node, send for TB culture. And once the TB culture comes negative, you can stop the treatment. But you don't really need to do that. 9 months of treatment and you can stop. And actually, as per the program, as per the science, recommendation 6 months of treatment. And you can stop. I give 9 months, I said 9 months. So with this, also I want to say a huge thank you to all the wonderful delegates who asked so many questions. Dr. Ajay Lanjivar is my friend. He's asked 2 questions. I'm going to call him up and give the answer. Dr. Rushali, my dear friend from Pune, I'm going to call her up and give her the answer. Huge thanks to Dr. Mukul Saini, Dr. Atul Francis, Dr. K.L. Prajapati, Dr. Deep Kothari, Dr. Anu Varghese, Dr. Govind Desai, Dr. Shubham Chaudhary, Dr. Vijit Saxena, and Dr. Nina PS, Dr. Mukul Saini, Dr. Vamshi, my friend, Dr. Vamshi K, Dr. Mahendra Sharma. So thank you very much. There are just so many questions. We have about 50 questions which we have not answered. So maybe we all will meet personally very soon, the 3 of us and all of y'all, and we'll answer them in person. So huge thank you to Dr. VP Singh and Dr. Rajesh for making this a fantastic deliberation. I myself learned so many points, so many finer points, which were not clear in my mind. You all have helped me really learn them all over again. A huge thank you to delegates, a huge thank you to Mankind and to Indian Chess Society. And I would now like to move on to my dear friend, Dr. Rajadhar, who we all know is one of the most academic and one of the most cheerful person who really likes to indulge into academics. So thank you, everybody. Good night, and over to our dear friend, Dr. Rajadhar. Thank you.
That brings us to the conclusion of day 1 of the Best of Napcon. It's been a pleasure to bring you this meeting. I hope you've enjoyed it as much as I have, listening to all the moderators and the subject experts. We have tried to give you a perspective of 3 different spheres of respiratory medicine. We've obviously not managed to cover everything, and that was not the aim either. But hopefully, you've had a flavor of these subspecialty areas. We will bring you more of the same on other subspecialty areas on the 17th and the 24th of June. I look forward to hosting you for Napcon, the very best on those dates. Stay safe, stay healthy, and hopefully I'll see you again on the 17th of June at the same time. Thank you for listening in. Thank you on behalf of the Indian Chess Society, and thanks again to Mankind Pharma for having hosted this meeting for all of us.
Manish, stop live now.